of everyone. I welcome you all to today's webinar, and I think this is an ongoing effort which will take us further in learning from each other. So teachers will teach the students, and students will teach the teachers, I would say. And nocturia, as Dr. Chawla very rightly just now mentioned, is one of the less understood subject in urology. Like prostatitis, everybody gives one medicine or the other, but doesn't understand the pathophysiology of the process, and it's very difficult to draw a conclusion very often, and we get stuck. And without wasting time of everyone, I think we'll go on to the presentation. Just one request to everyone, that because this is a program which is on Sunday, everybody has got his own commitments. Let us stick to the time which is allocated for each and every presentation. So I would request Dr. Rishi to start the program, please.
Sir, thank you, sir. As you all know, this is a program focusing specifically on nocturia, which is one of the most important lower urinary tract symptoms, as we all know. And the program has been charted out with the help of the conveners, Dr. Gautam Banga and Dr. Amar Kumar, who have devised it. And overall, we are focusing in this particular event on the state of Uttarakhand, where a large section of the members from the Uttarakhand have been involved, and the rest of the faculty we have chosen based upon their experience in the field. So today we also have a female and functional urology section of India being represented by Dr. Pawan Vasudeva, who is the secretary, and Dr. Sanjay also, who is the president of the section. I think I would now leave it to the conveners, Dr. Gautam Banga and Dr. Amar, to take it from here. Maybe from in the first section, Dr. Gautam can channelize the things, and in the second half of the meeting, Dr. Amar can take it. Dr. Gautam, please. Dr. Gautam? You are not audible.
Unmute yourself, Gautam.
No, you're still not audible.
I think Dr. Amar can take over if there is a problem with Dr.
Yes.
Amar, you can start.
Hi, sir. Yeah, good morning, everyone. Very good morning to everyone. Am I audible, sir?
Yes.
Yeah.
Yes, sir. So, as a part of RAISE and RISE initiative of North Zone USI, for today's showcase of Uttarakhand state, I, Dr. Amar, welcome you all for this webinar from the Devbhoomi, Uttarakhand, Dehradun. And this webinar of the initiative to bring all the members together for the academic, professional, and scientific achievements. So I would like to congratulate our North Zone President, Dr. P.P. Singh sir, and Secretary Dr. Rishi Nair sir, for the wonderful initiative. And with this note, I would like to invite our President, Dr. P.P. Singh sir, for the presidential address. So over to you, sir, Dr. P.P. Singh sir.
I
think we go on to the presentation straight away, please.
Okay, sir. Sure, sir. Okay. So for the first session, I would like to invite.
Hello.
Yeah. For the first session, I would like to invite chairpersons. So our chairpersons are. One second.
Can I take it from here, if you don't mind?
Yeah. Please, sir. Gautam, sir. Yes, sir.
Dr. Hamid, Dr. Kamal
I was not audible at that time. Can I take it from here?
Yeah, please, sir.
Yeah, so as it is, as Dr. Amar has already introduced, so this is our first webinar, and the focus is on nocturia, which is one of the most common symptom with a patient who comes to us in Lutz clinic. but often ignored by us, and we only focus on the obstructive symptom. But this is something which is very bothersome. To start with, I'll not take much of time. And for the first thing, I invite that is the part which deals with the understanding of nocturia. And the chairpersons are Dr. Vivek Vijayan, Dr. Hamid Arif, Dr. Kamaljeet Singh, and Dr. Ashok Sharma, sir. For the first presentation, I'll invite Dr. Arun Chawla, sir, whose topic is Nocturia First Among the LUTs, Clinical Epidemiology. Sir, you are welcome to the webinar. Please, sir. Please take care of the things, sir, from here.
Am I audible? Am I audible, Uchi?
Yes, sir. Yes, sir. Please go ahead.
Yeah, so very good morning to all of you. And thanks to Uttarakhand Urology Society, Northern USI, as well as the section of Female and Functional Urology for giving me the opportunity to be part of this program. So I'll be talking about the nocturia first among LUTs. We all know that nocturia is one of the symptoms of lower unit tract. And the lower unit tract symptom is an umbrella of syndrome which covers storage symptoms, the voiding symptom, and the post-void symptoms. We have very clear definition of nocturia. It is a complaint that the individual has to wake up at night at least one time to void. But this has been quantified by International Continence Society in 2019 as the number of times an individual passes urine during the main sleep period. That means from the time individual have fallen asleep up to the time of its intention to rise from that period. I'll try to explain with an example. Supposing an individual sleeps at 10:30 and wakes up at 11 o'clock to pass urine, again goes to sleep, wakes up at 1 a.m. to pass a urine and is trying to sleep but not sleeping, again wakes up at 3 o'clock to void and falls for sleep, and wakes up at 6 o'clock to again to void. He has a nocturia of 4 times. But take an example of same individual. If instead of going to sleep after passing urine at 6 o'clock, he has risen up for the day and continues normal activity, this nocturia will be as nocturia of 3 nocturnal voids. Now, we know that quoting from different guidelines, the prevalence of nocturia varies according to the age. A woman with in the age group of 20 to 40, 4 to 8% will have more than 2 episodes of nocturia as compared to the women which are older or beyond 70 years. One study of US focusing adults between 30 years to 80 years identified that 28% of this population have nocturia, and they have correlated this nocturia with association of increased BMI, prevalence of cardiac disease, type 2 diabetes, and diuretic disease. But more worrying factor is that 30% of these patients, individuals having nocturia, have more than 30%, one third more risk of death when they are having nocturia. Now, this is quite old data, but it's a very significant data. It indicates that if you see the population of 20 to 40 year, both in men and women have almost similar prevalence of nocturia. Around 11 to 35, say average of 25, 20 to 40, say an average of 30. And as the age advances, this more than one void in 70 to 80 years is almost similar. With men likely slightly more than the females. So as the age advances, the nocturia episodes increases in both the genders. This is a nice description of the prevalence of nocturia. The upper red being a representation of one void, and the bottom blue being the representation of more than 4 voids. This is the data from the a study of a meta-analysis of 43 studies, which has shown that nocturia is a prevalent condition in both male and female, and it is almost equal in male and female in terms of the number of voids in the night. And if you try to look at this data close to 20 year in females and close to 20 year in males, around 30% of the women in close to 20 years will have more than one void. And similarly, close to 20% of the men will have more than one void at night. So that is the prevalence across both the genders as in terms of the age. This is again the analysis of a EPIC study, which is of 20,000 patients across the Europe and Canada. If you see the as the age advances, the number of nocturnal void increases. And if you see, if this is the 40-year limit, you have a significant number of population, which is close to one third. So one third of the population less than 40 years has nocturia. And in this one third of population, which is less than 40 years, 13 to 70% will have more than or equal to two voids per night. Now, if this was a Western data, let us go across to the Asian population. One of the study reported from the Korean men across 2,000 population between the age of 40 to 70, which are a community population. Two-thirds of these men were having nocturia, and 20% have nocturia more than two times. And the storage lower tract symptom was more common, and these increases when the age increases. So from 40 to 78, as the age increases, the storage alerts became more common and the incidence of nocturia increased. So nocturia doesn't come alone as on its own as a single symptom. Usually it is a combination of other lower limb tract symptom. That means the storage, the voiding symptom, as well as the post-maturation symptoms. On the left side is the graphical representation of the female lower limb tract symptom. On the right side is the graphic representation of the male lower limb tract symptoms. And this study from APICS indicate that the LUTs increases with age and the storage symptoms are more prevalent than voiding or post-maturation LUTs. And out of these, nocturia was the most common reported symptom, which we often try to neglect or underrate this. And based on this EPIC study, which is a community-based study of lower tract symptoms across Europe and Canada, based on these, you can anticipate there are millions of men and women of the age 18 and above who have symptoms of OAB, urge incontinence, including nocturia. Now, nocturia definitely cause some sense of bother as well as affects the quality of life, which can be easily studied with a validated questionnaire. We have NQL or ICQL NQL validated questionnaire, which has 13 items scored on two domains, one on the sleep and energy and one on the concern of bothers. It is both suitable for the men and the women, and it is available across different languages. And we know as the number of voids increases in the night, the more bothersome is the symptom of nocturia. However, we have to note that a person voiding once in a night can have more bothersome. Example, if a person have 3 to 4 voids in the night, but is able to sleep after each void, will not have that bothersome score. But if a person has only one void in the night, but is unable to sleep after that void, will have more bothersome score. So it is very important to understand that what is the bother which can be easily affected from the quality of life questionnaire. We know that it's a multifactorial etiology of the nocturia, and we need to understand that venous and prostate obstruction and underactive bladder because of obstruction, large vessel urine can lead to nocturia. The overactive of the bladder with number of frequent void in the day and night can lead to nocturia. And similarly, the reduced bladder capacity can lead to nocturia. And on the same time, you need to remember there are causes beyond that. But what we need to understand that nocturia is LUTs if it is due to lower urinary tract dysfunction, if it is because of OAB, chronic pelvic syndrome, BO or bladder pocket obstruction, or disease or underactivity. And for us, Nocturia is not a lust if it's due to any other cause, like drinking a lot of alcoholic beverages, say taking a lot of coffee, nocturnal polyuria of any cause due to sleep disorders, or there is any systemic cause related to diabetes or any other systemic illness. Now, what we need to understand is as the age advances, we have more increased incidence of OAB, nocturnal polyuria, and benign prostatic obstruction. So we need to look at evaluation and treatment of more than one factor in these patients presenting with nocturia. Now, we do believe that it can happen in the isolated component, but the studies indicate that it is, in majority of the cases, is associated with nocturnal polyuria. This is an example of a bladder diary of a patient who has come to us with with the episodes of nocturia. If you see here, the number of whites in the day and the night, and if you try to calculate the diurnal volume and the nocturnal volume, the day volume are just 700 and the nocturnal volume is 1280. So it is the nocturnal polyuria which is a cause of nocturia. And bladder diary is important to calculate many other indices which will not go into the detail. And there have been evidence where the bladder diary has been used to separate the nocturia and its subtypes from various indices. So this bladder diary can easily classify that nocturia is because of nocturnal polyuria or decreased nocturnal bladder capacity or global polyuria or a combination of. Again, it's a lower unit factor network cohort study which has indicated that bladder diary properly maintained over a period of 3 days can lead to the identification of the subtype of nocturia, which can be global polyuria, nocturnal polyuria, reduced global bladder capacity, or an isolated nocturia. The status of nocturia lies that it can lead to reduced sleep efficiency, which I think Pawan will be covering the whole subject in detail, reduced productivity both at the work and home, reduced quality of life with increased incidence of organ fracture, with definitely increased risk of cardiovascular morbidity and mortality. I'll skip this. I'll try to conclude my talk with carry-home messages that nocturia is highly prevalent and it is prevalent as well as in general population as young as 20 and across both the sexes. It is often an independent entity and not just a part of symptoms of BPO or OAB. And many nocturia patients will have nocturnal polyuria as the cause, in which case nocturia is not a LUTS. Many men are often treated unsuccessfully, assuming their symptoms because of the benign prostate obstruction. As we know that this nocturia as a part of NUTS increases with age. Nocturia needs to be properly evaluated and treated in addition to other bothersome labs. Thank you very much.
Thank you, sir. I think we'll take the questions after the second talk also. With the permission of the chairpersons, I think, shall we proceed for the second talk?
Yes.
Yeah, I
So
think
thanks for the elaborate epidemiology of the nocturia, and it's a well seen and well checked symptom which we come across in the patient. So inviting the second speaker, Dr. Pawan Vasudeva, who's the secretary of FFUS, and the topic is nocturia, sleep, and melatonin. Welcome, Dr. Pawan.
Good morning. Am I audible? Am I audible?
Yes, Dr. Pawan, you are audible.
So good morning, everyone. At the outset, I would like to thank the North Zone Urology Society of India, Dr. Rishi, Dr. PP Singh, and the Uttarakhand Society for this collaboration. So in the next 10 minutes, we will look at some aspects of sleep. Why is it important that you should be sleeping adequately? the interaction between nocturia and sleep and the role of melatonin. So essentially, nocturia and sleep have a bidirectional relationship. Nocturia can disrupt sleep, and at the same time, primary sleep disorders can result in nocturia. So first, how much should you be sleeping? So the American Academy of Sleep Medicine came out with these figures that an adult should be sleeping 7 or more hours per night on a regular basis to be promoting optimum health. Less than 7 hours is associated with adverse health outcomes, and if it's on the higher side, well, it is uncertain if that increases, if that is a problem. But 7 hours is the period that they came up with. The importance of sleep, we all understand that sleep is important to recuperate and restore physical and mental function. Sleep affects all organs, and it is important for optimum functioning of the endocrine, metabolic, and immune systems. Sleep deprivation disrupts biological rhythms, and the World Health Organization, in a statement, said that sleep is a basic human need, essential for good health, good quality of life, and for performing well during the day. Uh, Sorry. So what does shortened sleep duration do to you? So we all know that if you don't sleep well at night, next day you may be tired, there may be daytime functioning issues, but beyond that, what can happen? So this was a systematic review published in 2017, which looked at 108 prospective studies, and they divided people between short sleep duration people, which is less than 6 hours, and more than 6 hours, and they looked at various parameters like mortality, diabetes, hypertension, cardiovascular disease, coronary heart disease, stroke, and so on. And what did they find? They found that the incidence of outcome increased for short sleep duration. There is a higher incidence of obesity, relative ratio being 1.38, higher incidence of diabetes, higher incidence of coronary heart disease, hypertension, and mortality itself is also higher in people who sleep less. So what is happening? Why is sleep leading to this, to these? So the physiology behind this is that if you sleep less, it leads to an insulin-resistant state in the body, inadequate secretion of insulin from the pancreas, the appetite hormones go haywire. There is increased sympathetic activity and resetting of the arterial reflex. Now, it's not only the sleep duration which is important, it is also the sleep efficiency which is important. When we say sleep efficiency, we are meaning the ratio of the total time that you sleep to the time that you spend in bed. And there was this study which found that for people whose sleep efficiency is less than 80%, their survival is much lower. So going further, diving deeper into sleep, we all know that sleep has it alternates between non-REM and REM sleep, and these are about 4 to 6 cycles each night. And as the night progresses, the REM sleep will increase, and you get up from REM sleep. So when you wake up, you get up from REM sleep. Now, what is important is if you look at this first 4 hours, the non-REM sleep has stages 3 and 4, which we call as the N3 stage. It is this N3 stage which is important from a restorative sleep point of view, and this predominates initially in the first 3 4 hours, and then it goes on decreasing. So this is called as a slow wave sleep. So this is the period which is important. And if you wake up during this period, if your patient with nocturia is getting up during this period, that will have a larger impact than if he was to get up later in the night. And that is from where the concept of first uninterrupted sleep period has come, which means the time that you go to bed with the intention of sleeping, and then the time that you wake up for your first void. Now, so this was about sleep and its importance. Now, what does nocturia do to sleep? So there was this study which looked at about 1,500 people, and they were asked questions on what they perceive is the reason for their sleep disturbance. And these questions, it could be nocturia, headache, money, family problems, and all of that. So people who were getting up almost every night, more than 50% of them attributed nocturia as the cause of sleep disruption. So, nocturia leads to a significant reduction in sleep duration. The more severe is the nocturia, the more significant is the reduction. It leads to fragmentation of sleep. The efficiency of sleep goes down, and the overall global sleep quality is affected. Now, if the first nocturia episode was happening later in the night, it would still be, it still may work. But in this study, they looked at what is the median time to the first nocturia, and they found that in this study it was 1.9 hours, and on an average, the patient would have his first nocturia episode within the first 2 to 3 hours, which means that nocturia is affecting that portion of the sleep which we don't want it to, so it ends up impacting the slow wave sleep. Now, this impact on the slow wave sleep of nocturia, does it translate into poorer health outcomes? Well, there was this systematic review in 2020 which looked at about 20,000 men, and they found that people who have nocturia have an increased, there is moderate quality evidence that it is a prognostic factor for an increased risk of mortality. And they attributed the causation to nocturia being a relevant disruptor of sleep. Does nocturia affect morbidity? Well, again, another systematic review which looked at again the same 20,000 people and found that with nocturia there is a increase in the relative risk for falls and relative risk for fractures. So we understand that nocturia, that sleep is important. Nocturia is disrupting sleep. Now, if you address nocturia, does that improve outcomes? So, treating nocturia can increase the first uninterrupted sleep period. This would lead to an overall global sleep quality improvement. It also increases the odds that the patient will sleep longer. And it has also been shown that it improves the metabolic consequences which were coming up related to diabetes, metabolic syndrome, hypertension, and so on. So on the other side, then you have sleep disorders which cause nocturia. This was nocturia affecting sleep. Then you have sleep disorders causing nocturia, and you have a host of things from insomnia to narcolepsy and so on, which can cause nocturia. And the essential difference in them is that the patient gets up and then goes for a convenience void, versus when a patient is getting up because of a full bladder to pass urine. And this history sometimes can overlap, but this is a history that you need to accurately take when you are speaking with the patient. Now, within this set, what has been studied in detail is obstructive sleep apnea and nocturia. And so nearly one third of patients with OSA have nocturia. But if you look at the nocturia population, less than 1% of patients who have nocturia will have OSA. The pathophysiology is fairly well defined. There is an increase in the atrial natriuretic peptide leading to nocturnal polyuria. So your patient, when you get your voiding diary made, if your patient has nocturnal polyuria, you must think about OSA. But on the other side, normal patients with nocturia and OSA who did not have nocturnal polyuria can also, so the reason is OSA patients they sleep lighter. So even if they did not have nocturnal polyuria, managing OSA could still help them with their nocturia. So in the OPD, how can you find out these patients? You have easy questionnaires like the Stop Bang questionnaire, which is eight simple questions, and this has a sensitivity of more than 90% for picking up patients who may have OSA, your nocturia patients who may have OSA. Does CPAP? So now, if you find out such a patient, would CPAP improve nocturia? Well, a recent systematic review has found that CPAP is robust in the treatment of nocturia in patients with OSA. Nocturia frequency nearly halved, and the mean night urine volume increased by more than 150 cc. Coming to melatonin now. So we understand that the body has a circadian system, which is essentially a 24-hour internal clock in our brain, which regulates the cycle of alertness and sleepiness. and this modulates the rhythm of all your organs. So the master clock for this circadian system is in the suprachiasmatic nucleus, and then you have peripheral clocks in all the organs. What melatonin is doing, it is synchronizing these two, the peripheral clock and the central clock, and this is secreted by the pineal gland and also locally secreted. Coming to melatonin and bladder, so now bladder is also believed to have a circadian rhythm of bladder, and there are various explanations for this, from genetic to gap junctions to iron. Essentially, what is happening in this circadian rhythm is that during the active phase, the voided volume is increasing, and during the resting phase, the voided volume is going down. So, what about then melatonin and nocturia? So, as such, the melatonin levels decrease with age, and night serum melatonin levels in elderly patients who had nocturia were lower than those who did not. And this is a recent trial which looked at women in whom melatonin was given for nocturia, and it was found that it increased the median. It did help, and it increased the first uninterrupted sleep period and improve the quality of life in these patients. So to conclude, nocturia is a leading cause of sleep disruption. Inadequate sleep is potentially dangerous, so you should not ignore your patient who says, "I get up 5 6 times, but I'm not really bothered," because that inadequate sleep is dangerous from all the metabolic consequences that it can bring. The first uninterrupted sleep period is a key metric which you should incorporate in your practice when you're setting targets for nocturia treatment, as in when you're looking at their diaries, how long they should sleep. That first interrupted sleep period, your target should be 3 to 4 hours. And the role of melatonin is evolving in bladder disorders, including in its role in nocturia. Thank you.
Thank you, Dr. Pawan, for elaborating this talk and showing the importance of the sleep in our life. Now, I request all the chairpersons to take over the things, and we can now take the questions for this session. I welcome all the chairpersons.
Yeah.
Right. Pawan,
Dr. Sheikh Vijin, Dr. Hamid Arif, Dr. Kamal, and Dr. Ashok Sharma. Sir, please take the thing. Take
Dr.
the
Pawan,
this session.
Dr. Pawan, what as a urologist, what is your experience of treating patients with melatonin?
Sir, recently started, so I don't have a very large experience. But uh, for people in whom um, there is some element of sleep disorder and nocturia, it helps more than in which you're looking at it from a primary nocturnal polyuria point of view.
Dr. Arun, do you have some experience of treating these patients? Dr. Arun Chawla, your experience with melatonin?
No, no, sir, not at all.
No. Pawan, what medicine are you using for? Is it freely available in market?
Sir, it's freely available. So trials have used 2 milligram, but what is available in India is 3 milligram. So you give
What is
that one.
what is the
One
brand
hour.
name like?
Sir, there are many brand names. It's easily available because sleep people have been using it. So and it's fairly cheap. It's not an expensive medicine.
It's available by the name Nocturia.
Pardon,
It
sir?
is easily available.
Sir, it's easily
Yes.
available. There are enough and
It's
more brands.
easily available.
Anyone among the panel, Dr. Kochar, or anyone has larger experience of using melatonin, because nocturia remains the mainstay of the complaints for many patients in urology.
The melatonin has come into the Indian market recently,
Yes.
but previously we were also using desmopressin long back, and then more recently we were using mirabegron also. All of these help in nocturia.
So from the, can I ask one question, sir? So from the pathophysiological point of view, using sedatives like benzodiazepines that are more commonly used for inducing sleep versus use of melatonin for uh, uh, restoring the sleep cycle, which one is going to have a more effect on correction of nocturia? Dr. Arun
So
or
I,
Dr. Yeah.
so I think if you're suspecting a sleep disorder, the patient should visit a
Psychiatrist.
respiratory guy, because sleep disorders from anxiety to depression to whatever, their medication will differ, even though all of them may have a sedative portion to it. So if once a sleep disorder comes into the picture, I think the respiratory person should take over.
So when should one suspect that it is the sleep disorder induced LUTs rather than the LUTs causing the sleep disorder?
So how I do is, if I find nocturnal polyuria in the patient and there is no pedal edema, he goes to a respiratory physician for to rule out OSA if there is nocturnal polyuria. And if there is no nocturnal polyuria, then I try to thread this, that whether it is a convenience void or the patient is actually getting up because of a full bladder. If there is an element of convenience void, then I again send him to the sleep person for an opinion.
So there's a question by Dr. Jitendra Amlani. Is there any Indian data of nocturia and sleep duration available with us at the moment?
Not to my knowledge.
So we can work on it. We can always take up a research project for North Zone for this year.
Dr. Tanuj is asking, is there any role of other sleep-inducing agents in treatment of nocturia?
Sir, so if the cause of nocturia is a sleep disturbance, then the sleep medicines will obviously help. But if the cause of nocturia is, let's say, OSA, then a alprazolam or so it depends on whether you're able to reach to the cause of the sleep disorder.
Right.
Yes.
I'll add.
It's Dr. Arif here. Can I come in?
Pawan, can I add? Now, what
Yes,
we are
please.
talking, what you're asking is absolutely right. So, what we see in our practice is, again, from the experience, from what we have gained, and from the previous Abraham's visit to Manipal 2 times. So, we try to look at nocturia as a component which is fitting into the urological disorders. Beyond that, it is always for us is a multi-specialty or a multi-departmental team approach. So this is involving both the respiratory. They have a separate department of sleep and sleep disorder along with the neurology. We have seen patients getting sedatives and other drugs and then ending up with what you can say incontinence in the night. So that type of medicine fact also we have seen. So we need to look at what we have to do on our own and what needs to be a interdisciplinary consultation and the management of patient.
Sir, also you need to see the void in diary very closely. So let's say
Absolutely.
the day voids are 200, 300, and you have the person getting up at night 2 times with 500 cc voids. Now, Mira background is not going to help that patient. That patient,
Absolutely.
the etiology is different. So the void in diary does help you to reach, whether it's urological or non-urological.
Yeah, Pawan, I totally agree, and I think that should be a religious practice in patient having nocturia or LUTs to have a well-maintained diary. Our USA guidelines say even 1 day is enough, but if you have more than 1 day properly maintained diary, it is more than enough in looking into depth of what type of problem we are dealing with. I totally agree with you.
Some comment from Sanjay. Sanjay is here. Sanjay Sinha.
Hey, hi. So I listened to the last part of the discussion, not talk to everything, but I am a little perturbed by the direction that this is taking.
Yeah.
So it almost appears to me that if somebody comes with nocturia, we are recommending the use of melatonin. So I haven't heard all of Pawan's lecture.
No. That was not the.
Yeah.
No,
So let's be very clear. A patient who has a sleep disorder is a separate category of patient, and that patient ideally should not be treated by us. Medication for sleep disorder is not the first line of management for sleep disorder. And do we know about sleep hygiene? So really, we are not the people to be prescribing a sleep medicine for somebody coming with nocturia. If somebody comes with nocturia, our job is to do a triage and see whether the patient has a urological cause for nocturia.
Yes,
And if he
yes.
does not have or she does not have a urological cause, our job is to refer to the right specialty, which is not the urology specialty for this
So,
case.
So that is
if
what I said, that
we
we
can
need.
label, so if we can label three important causes for nocturia, which one would those three most predominant causes be?
No, so our job is to see so if let's say the patient has issues related to fluid load, for instance, third space sequestration, short of an idiopathic edema, pedal edema, which is fine for us to manage. Any of the other third space sequestrations is not our responsibility. We would be doing injustice in trying to treat that, right? We are not here discussing should we give a diuretic to a congestive heart failure patient. So why should we be discussing whether we'll give melatonin to a sleep problem patient? That's not our field.
So that's what I said, that the voiding diary will help us reach whether it's likely urological. Like if
Absolutely.
you get large volume voids at night, then we have no business of it. I mean, then he is not ours, and then he goes to to whichever specialty he needs to.
Precisely.
So
Precisely.
pedal edema. So what
Yes.
I would do is pedal edema. You look for pedal edema. If it is there, then he goes for a cardiac and a respiratory opinion. And if you feel he may be having OSA, then you get the stop bang questionnaire done. And if that is suggestive, then you send him to the sleep person.
True. So in this sense, I don't think that the message going out here should be a patient comes in nocturia and we put the patient on melatonin as urologist. I think that's a wrong
No,
message.
no. That's not the discussion at all.
Yeah.
So that was not the
Correct. I just thought I haven't heard the rest, so sorry if I misunderstood the discussion. Right.
Yeah.
Okay.
The primary cause of nocturia in our patients who come to the urology clinic, because nocturia is a manifest symptom affecting the patient as well as the family. So the commonest reason we find is the residual urine in the bladder. The most important thing is, of course, lifestyle situations, depending on fluid intake at night. And the second most important is low urinary obstruction. And the third would be an overactive bladder.
Yeah.
So all of that would come by, again, you would be able to narrow down on the urology people by a diary and by a uroflowmetry and ultrasound.
Yeah.
And another common thing,
Yes.
at least which I see, is their habit that they're used to drinking a liter of milk before they sleep. And they feel that when I was 40, I was able to, I was never getting up, but now I'm 50 or 60, so why should it be happening? So I think the intake and the amounts that they're taking in the evening also becomes important when you're looking at the diary.
So when you are looking at the management of these patients, I think we must look at their lifestyle also, the fluid intake and the food habit. The late dinners and more fluid intake may be one reason of the nocturia. And just regulating the lifestyle may take care of the nocturia problem.
Yes, sir.
Could I add a
Yeah,
small?
yeah. Dr. Arif
Sanjay.
here.
Sorry.
Go ahead.
Yes.
Go ahead.
Yeah. This nocturia, basically, there is a lot of overlap in this symptom. And basically, we have to understand, is it basically because of the overproduction of urine by the kidneys, or there is a bladder issue per se? Because unless and until we focus on which component is basically contributing to this symptom, we cannot have all general measures. We have to be very specific, patients complaint oriented, and what is the basic issue, and accordingly, what is the neurological status, what are other comorbidities, what is the lifestyle. So we can then focus and evaluate. As urologists, it is our duty to properly evaluate what is the basic cause of the nocturia in an individual patient. So we can have very few general measures, but we have to be very specific to address the cause of the nocturia. Then only we can treat it. Regarding the role of melatonin and other things, I don't think, as Dr. Sanjay said, that's not our domain. That's the part of the sleep medicine. We have to focus more on the urological causes, evaluate it properly, and give a proper treatment to an individual patient. That is probably our role as such.
Last comment by Sanjay. That's all.
So there was some discussion about age, and so I just thought I'll give you the data from our recent PsyCom3 project, which is a young males presenting with lower tract symptoms, a multicentric project, 16 centers across India. 448 patients recruited. The most common symptom was nocturia. If you define nocturia as getting up once in the night, reported by 89.1% of young men who presented. It was also the most severe symptom, severely bothersome symptom in young men. So we think about nocturia as something for the old, but actually our study, which we are just going to present at the FFUS in April and be writing it up now, shows that even in young men, it's actually a prominent problem.
Thank you, everybody.
Thank you.
Over
Can
to
I ask
Rishi.
a question, sir?
Over to Rishi,
Sir,
yes.
can I ask a question to Dr. Sanjay?
Yeah,
Can
please.
I ask a question to Dr. Sanjay, sir? Now,
Yeah, go ahead.
You can. This is the last question for this session. So please, you. So
Yeah.
PP Singh, sir, please.
Just yeah. The question is, many of the cardiac patients who have got retention of the fluids and edema in the peripheries, when they sleep in the night, some of the cardiac output improves and there's mobilization of the edema and then they get nocturia. Despite the fact that we tell them to restrict the fluid in the evening, everything is done. But somehow these patients have somehow either a good circulation to kidney in the night and the production of the urine, if you count, is much more in the night hours compared to day hours. What is the solution to this problem?
So the solution to this, so one thing that is not a solution is using desmopressin. So patients who have got significant degrees of cardiac dysfunction should not be put on desmopressin. So what you need to do is treat the patient in conjunction with your cardiologist. Optimizing cardiology care is the key, but physical measures will all work. So putting, let's say, daytime stockings will help regardless of what the issue is. Okay, cutting down already they will be doing foot elevation periodically. Those kind of things, and perhaps dosing a diuretic in the afternoon in conjunction with discussion with the cardiologist. I can think of those general measures.
Yeah.
Over to Rishi now. Thank you, everybody.
And thanks, Chairperson, for chairing this session. We are running short of time, so we'll move on to the second session. And for that, I invite Dr. G.S. Kochar, sir, Dr. D. Dadamani, and Dr. S.S. Yadav, sir, and Dr. A.K. Sanwal, sir, to chair the session.
Dr. Somendra, please load your slides.
I invite Dr. Somendra Bansal for the first talk in this session. The topic of that is nocturia and microbiome. Welcome, Dr. Bansal.
A very good morning to all of you. And first of all, thank you for North Zone Society and the Uttarakhand Urology Society to give me the opportunity to deliver and talk on the urinary microbiome. Urinary microbiome is a recent topic, and in this recent year, much attention has been paid to the human microbiome. Human microbiome is important in the health and the disease. It is estimated that approximately 10 to 100 trillion human microbiome present in the human body, which is and gene of these microbiome are 10 times more than 100 times more than the human genome. So, what is the microbiota. Microbiota is the ecological community of the symbiotic and pathogenic microorganism, which include the bacteria, virus, fungi, and protozoa, which inhabited the epithelial surface of the body. And genetic material of these microorganism is known as the microbiome. These microbial community involved in various normal human physiological function and maintain the health and prevent the disease. Any the imbalance of this microbial community lead to the dysbiosis. And until now, it was thought that the urine was urine is sterile in the nature, but due to the development of the molecular biology, there is a recent development of the human urinary microbiome, and these their role in the urinary tract symptom, which lead to the lower urinary tract symptoms, overactive bladder, urge incontinency, and ICBPS. So previously, these microorganisms by detected by the culture-based method, which use the McConkey agar or the blood agar, but these culture-based method has a limitation to detect the anaerobic and the slow-growing bacteria. To overcome this method, metagenomic analysis is developed, which detect the viable bacteria by the DNA mechanism and through the rapid sequencing method. There are two types of the sequencing method. First is the 16S ribosomal RNA gene sequencing. Another one is the expanded quantity urine culture method. Expanded urine quality culture method uses the traditional culture techniques, but it also include the blood, chocolate, nalidixic, and colistin agar media, in which the colonies are incubated at the temperature of the 34 degree for 48 hours. It detects the bacteria which should not be detected by the normal routine examination, routine culture techniques. So recent studies recommended that 16 and RNA and the DNA sequencing method and expanded quantity urine culture techniques should be detect the 90% more bacteria when there was a negative urine culture. There are a difference in the diversity of the human microbiome, which depend on the multiple factor. One factor is the sampling collection techniques. There are different sampling collection techniques like the suprapubic aspiration, translethal catheterization, and the self-voided midstream urine sample. These is there are most accurate detection of the human urinary microbiome is the suprapubic aspiration, which detect the accurate bladder microbiome. But it has a very painful and the very painful technique. So another one is the self-voided, yeah, midstream urine sample, but it is contaminated by the perurethral, so it is not an accurate representative of the microbiota. There is a recent study which compared the transurethral catheterization sample and the suprapubic aspiration techniques, which shows that the results are similar to obtain the microbiome either by the transurethral catheterization or the suprapubic aspiration. So, transurethral catheterization can be used to detect the normal microbiota. The urinary microbiota is closely resembled to the 62% to the vaginal gut microbiota and the 32% in case of the vaginal microbiota. Whenever there is a disturbance in the gut microbiome, so there is a disturbance of the urinary pathology which lead to the overactive bladder symptoms. There are fewer published studies on the urinary microbiota in the healthy male as compared to the female, and male microbiome is closely resembled to the skin normal flora, while the female microbiome is closely resembled to the vaginal flora. So, lactobacillus is the most evidently seen in the female microbiome, and the cornybacterium and the streptococcus is mainly seen in the male microbiome. Apart from that, other species like the Provetella, Shigella, Staphylococcus pseudomonas are also seen in the male and female equally, but more frequently in the female. And Mycoplasma, ureaplasma is the commonly seen in the male microbiome. So, change in there is also difference between the young and the old age microbiome. These changes can be associated with the age, but age is not solely factor to diversity of these microbiome. It may be the secondary changes associated with the aging. So in the older female, menopause is an important consideration for the change in the microbiome. So there is a hormonal disbalance. So there is a in the premenopausal female, lactobacillus is the predominant microbiome, while in the postmenopausal female, mobiluncus is the most predominant microbiome. Lactobacillus is generally present in the vaginal microbiome, which maintain the vaginal pH and maintain the vagina healthy. And the similar effect of this lactobacillus in seen in the urinary microbiome. Byproduct of this lactobacillus metabolism, like the lactic acid and the hydrogen peroxide, inhibit the uropathogen growth, and which causes the maintain the urinary flora healthy, and lactobacillus is decreased in the postmenopausal female, so there is a increased chances of the recurrent UTI because lactobacillus inhibit the uropathogenic E. coli bacteria. It also inhibits the ATP and calcium ion released from the urothelium. Another one bacteria, Gardnerella vaginalis, which is most predominantly present in the bacterial vaginosis, and there is an increased chance of the recurrent UTI due to the Gardnerella vaginalis because it causes a re-emergence of the uropathogenic E. coli from the latent intracellular reservoir. When there is a increased Gardnerella in the microbial community, so there is it is also associated with the decreased lactobacillus communities. In the healthy male, in the healthy persons, male bacteria, Shigella and Provitella, both are seen in male and female predominantly. And in the male, predominant bacteria is Corynebacterium and female in the Lactobacillus. So these normal flora maintain the urinary pH 4.6 to 7. But whenever there is a disturbance of this microbial flora due to the risk factor like indwelling devices, age, low estrogen level, barrier contraceptive, vaginal infection, diabetic, or antibiotic, or spinal cord injury, which leads to the alteration of these normal microflora and causes the dysbiosis. In this cases, there is a decreased lactobacillus and other pathogenic bacteria increases like E. coli, Enterococcus, or Staphylococcus, or Gardnerella, which causes the UTI and lead to the increased pH. Some microbial stand identifying the urine sample in case of the overactive bladder symptom, and मतलब कुछ some symptoms are associated with the particular bacteria like frequency, which is associated with the Klebsiella, nocturia. Nocturia, there is a lacnospirical blutea bacteria, which has a protective mechanism against the for the nocturia, and there is some relation between the this L. blutea microflora and the IPPS score. In case of in presence of this bacteria, IPPS score is very good, and these there is a protective effect on the lower urinary tract symptoms. In case of the urgency, Bifidobacterium and Fecalis bacterium is identified, and in case of the urge incontinence, there is an increased Gardnerella and decreased Lactobacillus. And in case of the lower urinary tract symptom, when we are giving the anti medicine, there is increase. Despite the medicine, there is a chances of the progression and the non-responses of the disease, which can be contributed to the multiple etiology or heterogeneous factor. So, prostatic, in case of the lower urinary tract symptom, prostatic inflammation may be present, but their etiology cannot be clear. So one of the etiology is the gut microbiota alteration, which can be altered by the age, lifestyle, or the any drugs, which can influence the prostatic inflammation status indirectly by activating the immune system. And in case of the BPH, there is a high firmicutes and bacterial ratio in the gut microbiota, and short chain fatty acid from the gut bacteria promote the prostatic enlargement. So these findings support the existence of the gut prostate axis. And these gut prostate axis is the new target for the diagnosis and the treatment. Invasion of the bladder wall by the uropathogenic E. coli lead to the formation of the biofilm-like intracellular bacterial communities by the occult and recurrent cystitis, which may be undetected by the routine urine culture and escape the antibiotic. These may be this may be cause of the recurrent urinary tract infection and the persistent lower urinary tract symptom. Bacteriophage virus also play an important role in the stability of the microbial community, and these phages can destroy the uropathogenic E. coli biofilm, and these may be the further future of the management of the lower urinary tract symptoms. Inflammation may also role in the inflammation caused by the bladder and the prostatic and microbiota, and the inflammation caused by these inflammation lead to the storage and voiding symptoms, bladder fibrosis, and denervation. Increased basal release of the ATP in the urothelium is responsible for the intracellular bacteria in overactive bladder with pyuria. There are some urinary biomarkers for the overactive bladder, like the nerve growth factor and the brain-derived neurotrophic factor. Both of two are secreted from the urothelium or the smooth muscle. A nerve growth factor is responsible for the overactive bladder because it causes a sensitization of the afferent nerve ending of the peripheral nerve. So overactivity of the bladder is increased. Another one urinary biomarker is the microRNA. MicroRNA is a biomarker of the bladder dysfunction and storage symptom after the surgery. It distinguishes between the diffuser overactivity and diffuser underactivity, and this is a marker for the fibrosis and the bladder outlet obstruction. But this limitation of the microRNA is that for clinical application, it is have to obtain the tissue, and it is invasive in nature. Another biomarker is the urinary ATP, which inhibit and contact and relax the diffuser muscle and lead to the overactive diffuser overactivity. So, according to the European guidelines, don't routinely use urinary biomarker or estimation of the urinary microbiota in the diagnosis and management of the Lutz disease in the female. And prophylaxis with the vaginal probiotic like lactobacillus has a beneficial clinical impact for the prevention of the UTI. So to conclude the session, contrary to doctrine, urinary tract is the inhibited by the unique urinary microbiota. Further research is needed to characterize this microbial community in the health and disease. Alteration in the urinary microbiota have been linked to the urological disease such as neurogenic bladder dysfunction, ICBPS, and urge incontinence. Microbiome, particularly that of gut, has a key role in the development and progression of a disease within the urinary tract, and accurate characterization of the urobiome in various urological disease may allow for its extensive use in the clinical practice in the future. And these microbiome can be used as a prognostic and the therapeutic marker for the urinary tract disease. Thank you.
Thank you, Dr. Bansal, for the insight into the Nocturia and Microbiome Association. Now I invite the second speaker for the session, Dr. Rajiv Sarpal, who's going to talk about the clinical algorithm for evaluation of Nocturia. Welcome, Dr. Sarpal.
Doctor.
Good morning, everyone. Am I audible?
Yes, sir.
Yes, sir.
Yes,
You
sir.
are audible, sir.
So I would like to thank Northern USA for giving me an opportunity to talk on this topic. So I will talk on clinical algorithm for evaluation of nocturia. Now the ICS definition of nocturia is all clear. It is waking from sleep one or more times to void, and each void being preceded and followed by sleep. Next, why we should comprehensively evaluate nocturia? Because it has overall a negative impact on quality of life due to reduced sleep efficiency, reduced productivity because of daytime fatigue, and it also is associated with increased falls and fractures as the number of nocturia episodes increase, especially in elderly individuals, and is also associated with increased mortality and morbidity. Now, the etiology of nocturia is all clear. It is not only the urological causes which are responsible for nocturia, but there is a list of other causes. Non-urological causes are very important, and among these, nocturnal polyuria is most contributing factor. Now, again, it is all clear that if nocturia is associated with lower unit tract dysfunction, then we label it as a lower unit tract symptoms. But if nocturia is because of non-urological causes, then it is not a lower unit tract symptoms. So how to evaluate such patients? So first of all, for urological cause, we have to evaluate all the lower unit tract dysfunctions. We have to take a proper history. This includes all history of all the symptoms with which the patient has come, like storage and voiding symptoms. And there are various questionnaires available. And we can even use the bothersome criteria of each symptoms. Then we should take a proper behavioral history of the patient, behavioral factors responsible for nocturia. Some patients are just taking more number of fluids in the evening. Some are taking even caffeine and alcohol intake. History of this is also very important in evaluating nocturia. Then we have to review the medical history and the medications taken by the patients, especially the diuretics or the lithium in the evening. Then also we have to look for the relevant comorbidities which are responsible for nocturia, like diabetes mellitus or congestive heart failure. So all these things should be evaluated. And lastly, if we have to take a proper sleep history of the patients, and patients might be suffering from obstructive sleep apnea, there may be some apneic episodes, and this history is typically taken from the patient's partner. And most important thing in evaluation of nocturia is a validated bladder diarrhea, which is mandatory for evaluation of. Now, this is the bladder diary. We should instruct the patients to come with a 3-day voiding diary. So what information we can get from this voiding diary is what type of fluid he's taking and at what time, whether he's consuming alcohol, caffeine in the evening hours, then amount and what is the timing of the urine output. Then the number of nocturia episodes the patient has got, any leakage, all these informations can be collected from the bladder diary. Then how to analyze this bladder diary? Most important thing is when the patient wakes up early in the morning and his first void is basically belongs to the nocturnal urine output. Then patient voids from between 10 a.m. to 10 p.m. and at 10 p.m. he goes to bed. Now this is his daytime output. And once he sleeps and again wakes up and passes urine, and this is all the how many times he goes to washroom, all these are the nocturia episodes. So from this bladder diary analysis, we can calculate what is the nocturnal urine volume, what is the total output, what is the nocturnal polyuria index, which can simply be calculated by just dividing the nocturnal urine volume output by the total output. And how many nocturia episodes? Now, this patient has got 3 nocturia episodes, and his day output is 900. His nighttime output is 850, which is more than 33% at his age group. So he's probably suffering from the nocturnal polyuria. Now, nocturia can be classified clinically as a global polyuria. Global polyuria we can label if the patient has 24-hour urine production more than 40 ml per kg. That means if he's a 70 kg patient, then the output is around 3 liters. And nocturnal polyuria, again, the definition, this is age dependent. In younger individuals, if his nighttime output is more than 20%, then we label it as nocturnal polyuria. And in elderly persons, if the age group is more than 65 years and his nocturnal output is more than 33%, then we label it as nocturnal polyuria. Now, again, the patients may have a diminished bladder capacity, which is commonly associated with lower urinary tract dysfunctions. Actually, it is not a true anatomical diminished bladder capacity. Normally, the patients may have the detrusor underactivity, which may lead to low voided volumes. And lastly, patients may be suffering from some sleep disorders like obstructive sleep apnea, which may be contributing to his nocturia. Now, if we see nocturnal polyuria, the causes could be excess evening intake of fluid and water containing foods. So this history is very important from the patient. Then peripheral edema is again important. It may be there in younger individuals, may have peripheral edema due to relative inactivity. If they are not doing any exercise, just long hours, long sitting hours, it may contribute to peripheral edema and they may have a nocturia presentation as a symptom. Then most common cause of nocturnal polyuria, probably it is because of reduced ADH production in elderly individuals. There is a loss of circadian rhythm, and that is responsible for nocturia, nocturnal polyuria. Then again, in both these conditions, heart failure and obstructive sleep apnea, they may have nocturnal polyuria as a symptom, probably because of increased atrial natriuretic polypeptides. Now, again, if you see that most common association in nocturia is nocturnal polyuria. Even if you treat nocturia, still the patients, around 85% of patients not get treated because they have additional nocturnal polyuria in them. So after taking a proper history, you need to examine, you do a complete physical examination, general physical examination, you rule out, you see for any peripheral edema. Then you have to do a focused abdominal examination, especially the bladder palpations, then digital rectal examination, focused neurological examination. All these things are important to rule out the urological cause as a feature of nocturia. Again, some additional tests, they are recommended. These are ultrasound, especially with the post-void residual assessments, then uroflowmetry, urodynamic studies may be indicated to differentiate whether it is the outlet obstruction or it is the bladder hypocontractility as a cause of nocturia. Again, if you have suspecting some sleep disturbances, you can do sleep studies. You can refer the patients to a respiratory physician. Now, this is just the evaluation, how you can comprehensively evaluate nocturia patients. So first and foremost thing is the bladder diary. From the bladder diary, you can, there can be 4 categories. There is low bladder capacity. Low bladder capacity means there is no nocturnal polyuria. That means probably you are having a urological cause. Then you do all the investigations and then treat it accordingly. Or the patient may have nocturnal polyuria. If there is nocturnal polyuria, again, the cause could be congestive cardiac failure. Then you can have a cardiology reference. Or it could be because of diabetes mellitus, or it could be because of obstructive sleep apnea. Again, in those scenarios, you have to refer the patient to a respiratory physicians. Or it could be simply because of peripheral edema due to venous diseases. Or if the patient is consuming a lot of fluids in the evening, that could contribute to nocturnal polyuria. Or another scenario could be a polyuria or global polyuria. This, you can differentiate all the 3 causes. Maybe primary polydipsia may be contributing to his global polyuria, or it could be a central or nephrogenic diabetes insipidus. Or sometimes it is a mixed etiology. There may be some urological cause associated with some nocturnal polyuria. So just I summarize that nocturia is highly prevalent and associated with sleep disturbances which have wide-ranging negative consequences. Nocturia is an independent entity. It is not just a part of symptomatology of benign prostatic obstruction or overactive bladder. Many nocturia patients have nocturnal polyuria as a cause. In that scenario, nocturia is not a lower unit tract symptoms. And nocturia needs to be properly evaluated and treated in addition to other bothersome symptoms. Thank you.
Thank you, Dr. Satpal, for the algorithm. Now the session is open for discussion. I request chairpersons to take over the things and they can take the questions from the audience as well as they can interact with the speakers.
Hello.
Yes, sir. Yes, sir.
In microbiome system, it has opened another Pandora box, like in gut and respiratory tract. Now we have several microorganisms, which usually we don't get in culture. And once their role is established, but there are a number of studies which does not actually tell us clear-cut guidelines. Basically, lactobacillus is one thing which has come up. but rather rest of the things are vague. It's just a balance between. That is why so many persons have female. It is said that you should not treat asymptomatic bacteria. So until and unless there are symptoms, significant symptoms, then only role of and if there is a sterile urine culture, then the role of microbiome comes. Maybe in future we have much more studies come up.
Here I
Dr.
would like
Bansal,
to say,
we don't know as yet in which patient to advise investigation for urobiome and to look for inflammatory biomarkers in the urine. In which patient should we advise these complex tests? Anybody?
so there is a general theory that always we have been believing on competitive existence of Darwin. But now the theory of Lamarck is come, which is a cooperative one, which says that the human body and the microorganisms are not in competition with each other, and we should not be treating all the organisms that we detect in our body. It's a cooperative mechanism, and just like you have said that gut neuro axis, gut prostata axis, there'll be many other axes in the body. And so existence should be there, and all organisms should not be treated. They should be in a cooperative manner rather than in a competitive manner.
The question is how to use this biomicron in the treatment of UTI. Until unless we define it, then it is of just theoretical. What is the practical utility of this microbiotas in the treatment of recurrent UTI or in the treatment of this polyuria, nocturia, or OAB?
So can I say, yeah. So it is regarding the next generation sequencing with metagenomics of the urine. When you look at the urine and you find there are lots of pus cells, the symptoms are there, you do a cystoscopy, the bladder mucosa is friable, but you are unable to reach a microbiological diagnosis. So those are the cases in which you should go for next generation sequencing, because you have an inflammatory pathology, you have occasional pus cells, the cystoscopy shows friable mucosa. That is the time you are looking for certain organisms which are not culturable by usual methods of culturing. So those are the situations where you should use metagenomics and the next generation sequencing.
So, sir, as said, if we use these methods, we would be able to demonstrate some bacteria in almost every patient. While we have been able to show associations of the microbiome with these symptoms, lower urinary tract symptoms, the treatment part is still lacking based on this, because we have just
Rishi, you will not get in all these patients. These are very specific situations. So you have done a urine routine, you found pus cells, the cultures are repeatedly negative, you do a cystoscopy, you find friable mucosa, you find neutrophils in the biopsy. So there is an infection. These are the patients in whom the NGS, whatever it grows, it indicates, it picks up the DNA material. That is the time, that is the situation where you should take that organism, that lead seriously, so that you can treat these patients effectively. I'm not asking you to do it in everyone, but maybe you will pick up the organisms in these patients where you are frustrated anyway.
Yes.
That is
so how often is that? How frequent is that?
Oh, it is. In the referral centers, we see once a month at least a patient in whom we have to recommend a next generation sequencing with metagenomics. We do a urine routine. We may find 4 to 6 pus cells. The cultures are repeatedly sterile. The AFB is negative. The fungal culture is negative. The PCR for tuberculosis is negative. PCR for fungus is negative. So these are the patients. You do a cystoscopy because the patient has a small functional capacity, and you find that the bladder mucosa is all friable, inflamed, and is breaking down. You pick up these biopsies, you find you will have acute on chronic inflammatory exudates in the mucosa. Those are the patients in whom we send for NGS. invariably we find something, and we treat. Many of them are anaerobic organisms. Many of them are the rare vaginal pathogens, not pathogens, they would actually be rare vaginal organisms who
And
stay there and then they have found their way into the bladder.
and
There is
Dr.
a
Taneja,
small,
once
there is
you
a small,
get it, what is your approach? Whether you increase the probiotic sort of thing like lactobacillus and
That is
bacteria
always
which come
there.
in help.
So
Mm.
that is always
And
there.
also,
You cannot treat UTI without probiotics, because if you keep on giving chemoprophylaxis, you are only suppressing the microbiota. So probiotics, both of them are essential in your treatment modality. The only thing is that then we go back to first generation cephalosporins or linezolid, and these patients have had wonderful symptomatic relief with these simple medications.
I think that is a small group, non-responsive, and a lot to be done on that level to find
Yes,
out what is the
small group.
exact role.
I
Yeah,
agree, it is a small group, but you need to identify that small group, because
you
as
have
I
to
said, we
identify,
see.
you have to see what is the role, and
Yeah,
then what can be the treatment regarding this. So
yeah.
that is an area where we have to work little more about it, and probably we can get more results and we can reach to some conclusion at that level.
Could this inflammation be a part of the other inflammatory pathology, not a not a microcellular organisms as the cause of inflammation? Because we have found that inflammation is a problem in other areas of the body also, like in joints, in cardiac patients also, there is an inflammation, but inflammation as such ascribed only to microorganisms should not be there. There can be other pathology also leading to inflammation. So we should look into those parts also, into those aspects also.
As microbiota is living with the symbiosis of the body, then probably they should not give rise to the inflammatory reaction to the bladder or to the gut. Or
I
otherwise
think that's the
they are the pathogenic microorganism. We have to
no,
make the
but
difference
there,
between this. Yes.
exactly.
there are two types of microbiota which have been cultured in various studies. One are harmful, one are useful. So we have to see what microbiota we are getting. We are getting both types of ones which are causing inflammation, ones which are causing pathogenesis, and it has come up in prostate, it has come up in bladder inflammation, unexplained. So of course it opens a new future
Yeah, exactly.
Panadora box. It has to be researched, and then things will come up
More
much
work
better,
has to be done,
much
and it's
clearer.
altogether a different area.
Yeah.
Yes.
Another question is, example, what is the causes of nocturia in pregnancy? Because pregnancy, we have covered the nocturia. This is in the majority in the male, but in the female, good number of females having the nocturia in pregnancy. How to address and what to make the causes of this nocturia in pregnancy?
Dr. Rajiv.
Dr. Sarpal?
Yeah. Nocturia in pregnancy, I have no idea about what contributes to nocturia in pregnancy.
So in pregnancy, there is a volume overload as such, which is going to be a contributory factor, apart from the fact the bladder functional capacity is also reduced because of the gravid uterus. So beyond these two physiological causes, all other pathological causes can also be there during the pregnancy, but they are not specifically pregnancy induced. So the treatment of nocturia during pregnancy would actually be mostly conservative rather than using chemotherapeutic drugs. That I would think so. Any other opinion?
I think it's
No,
very
I think
difficult to
output
treat.
is increased, the GFR is increased in pregnancy. So
So there
there's
is
an
a
overall
volume.
increase in the output, and therefore there's nocturia. But this can be treated with drugs. I believe melatonin is safe in pregnancy also.
But
So I think
how melatonin will treat that?
fluid management can take care of the nocturia problem in pregnancy.
I don't know. I guess you have to give something so you can try this. I don't know if desmopressin is safe. I don't know if mirabegron is safe. Those two drugs are generally not recommended in pregnancy. But to mitigate nocturia, you could use melatonin, apart from other conservative measures which have been already enumerated.
So melatonin is basically, sir, used for sleep disorders where nocturia occurs because of that. Other than that, there is net retention of water in pregnancy, which invariably happens because of the increased estrogen. And that is to be, if the nocturia is too much bothersome, we can reduce the output in the daytime. Suppose sometimes a lady sleeps in a day also. That time water mobilization takes place and things. See, same thing has been practiced in the cardiac patients also. If he sleep conservative measures as has been mentioned.
Do we have studies showing that melatonin reduces the nocturia?
Sir,
Because
I have my
melatonin,
lecture following this lecture, so I'll discuss detail. And just one thing I want to add regarding pregnancy. Melatonin is not proven safe in pregnancy. It's not proven safe in
that is
pregnancy,
another
so one
question
should
which
avoid
is,
it. And secondly, in pregnancy, this is all nocturnal polyuria or global polyuria. So we need to treat in that way, not just that this is a particular nocturia. This is kind of nocturia because of smaller bladder capacity, because of gravid uterus, increased GFR, increased intake, pedal edema. These all things contribute to polyuria kind of. So we'll discuss in my lecture also. So in in pregnancy, the nocturnal polyuria can be a global polyuria, and this should be treated in more like a lifestyle modification, not just with drugs, because melatonin or desmopressin, these are not proven safe in pregnancy.
we are looking forward to your lecture.
Yes, yes.
So I think we move on.
So thanks, Chairperson, for chairing this session. And now we move on to the second part of clinical management of nocturia. Dr. Amar, please take over the proceeding from here. Dr. Amar?
Yeah, thank you, Dr. Gautam. So moving forward, I would like to invite our chairpersons, Dr. Deepak Garg, Dr. Sanjeev Gupta, Dr. Ramesh Sethia, and Dr. Iswaram Dayal. And our next speaker is Dr. Ankur Mittal. He will be presenting on urodynamics in nocturia, good clinical practice. So over to you, Dr. Mittal, sir.
Yeah, good morning, everyone. And at the outset, I would like to thank NZUSI and UK-US for this opportunity. Actually, from the morning sessions, we have been hearing a lot about nocturia, epidemiology, evaluation. My mandate for next 10 minutes will be, is there any role of urodynamics in this evaluation on nocturia, and how we can help our patients doing this study. So just to reinforce, we all know what ICS says about nocturia. Now we are all aware of this definition. We all know it. Most important part is, that followed by sleep or intention to sleep. Prevalence, yes, definitely, it is not a minor problem in the community. Prevalence is high, but really it's approximately 28.4%. But the most important thing will be what is important, when to treat and whom to treat. See, we can have a lot of nocturia patients, but the association and correlation is very important when we should chip in as a urologist. The etiopathogenesis, just to sum up, we can have a urological cause, we can have nephrological cause, we can have hormonal causes. We have discussed a lot about pregnancy right now, sleep disturbances, cardiovascular, and simple intake output, a simple problem leading to a major problem in OPD. Just a conservative management lifestyle helps us. Going ahead with the role of urodynamics, any urodynamics, what we talk about, a good clinical practice needs a very good initial evaluation. If the evaluation is good, and the most important part of that is bladder diary, which we have already discussed in the previous lectures. These interpretation of a bladder diary, if done properly, counseled properly, made properly, then only these interpretations probably will help us as a urologist. Most common, nocturnal urine volume, nocturia index, nocturnal polyuria, and nocturnal polyuria index. And then comes the global polyuria, which we have discussed earlier. Coming to the role of urodynamics in these patients, we had a paper in 2018 where we have the International Continence Society Consensus on Diagnosis and Treatment of Nocturia. And it was a beautiful paper. In the whole paper, if we come across the role of urodynamics, what the ICS suggested was whenever we suspect a reduced voided volume, then imaging, urodynamics, and occasional cystoscopy are performed as and when appropriate. So we need to really know when we can do urodynamics and how it can help us. Once we are searching the literature only on nocturia patient, whether they are predominantly nocturia or isolated nocturia, there are no clear recommendations from guidelines regarding urodynamics at present. But yes, when we go in detail, there are some pointers that whenever we find a low voided volume in our patients, whenever we evaluate if we are suspecting a urological cause, and yes, whenever we have these patients where we are planning to do some sort of a surgical intervention, which is an invasive form of intervention, it's not, there is no harm in getting this investigation and urodynamics done, which can make us more wiser. This frequency volume chart analysis was discussed by my previous speaker, Dr. Sarpal, and I think it is important to understand this voiding diary and these two causes, which are mainly the urological causes. And if we see in our daily practice, they are usually mixed, It's very rare to get isolated symptoms now. Usually the more population are mixed population, which are a mix of your urological causes and the causes which are not urological. So I think as a urologist, we really need to demarcate between these. Among all these causes, when patients with nocturia come to us based on the voiding diary, not all the causes are causes where we go ahead with urodynamics. I think the most important causes where the role of urodynamics chip in is if we are suspecting an infravesical obstruction, if we are suspecting a neurogenic bladder, and if we are suspecting a learned voiding dysfunction. If I need to rate, see, the first two things probably are not usually missed by a urologist. But the third thing which we are talking about, learned voiding dysfunction, or we can say a dysfunctional voiding, which is not a neurological cause, probably is an important part in this subset of population where the role of urodynamics comes in. So what about the other causes, what we're talking about, global polyuria and other causes? I should say definitely if we can identify these causes which are not urological, except when I search the literature, if you are suspecting OSA, the role of urodynamics is not proven in other cases because the management is totally different. But yes, if we are suspecting OSA, and there is no harm in suspecting OSA as a urologist also, before we refer the patient to a sleep physician. That can be done simply adding some questionnaires to our daily, what we use an IPSS questionnaire. We can add 2 more questionnaire about sleep quality and your OSA questionnaire, which is Berlin questionnaire. And I think give us a pretty good idea whether we are suspecting a high risk population of OSA with our LUTS patient. In that patient, we can say there is some role of urodynamics in these patients. In this article, what they did is all the proven cases of obstructive sleep apnea, all those patients, they had nocturia or nocturnal polyuria as a major complaint. Urodynamic investigation was done in all those cases. What they found that in these cases, the most important urodynamic finding was weak detrusor contraction, poor sensations, decreased compliance, and detrusor external sphincter dyssynergia. And these patients, when treated by a modality of CPAP, which is gold standard right now in OSA patients, and then the repeat investigation by urodynamics was done in those cases, they have found a significant improvement in detrusor overactivity, underactivity, or compliance. So this is one thing which can just tell us something that, okay, there is some sort of association between these two entities. The most important thing, whenever we do, how to do. If we do a urodynamic and if we follow a standard ICS standard protocol, I think that is more important, because these patients where we are doing urodynamics, whether they are neurogenic or infravesical obstruction or learned dysfunctional voidal patients, I think these cases are more challenging to do a urodynamics as compared to other cases of urological where we do it. So we know these all clinical history, examination, bladder diary, and a good complete ICS standard urodynamic test is very important. So if we see in these cases, I will not go through how to do a good urodynamic in these cases, but there are certain important pointers and points. So the media of bladder filling in such cases need to be important. ICS recommends that temperature of filling medium should be at physiological temperature. We all know that what is maximum physiological filling rate. We know the body weight, if divided by 4, it approximately ranges 20 to 30 ml per minute. And we all use it for our urodynamics test. But in such cases of when we are dealing with these 3 categories, we may need to tailor a lot. Because if we don't tailor our, doing a urodynamics, like if we are having a case of urgency or DO, we need to stop filling and wait to settle down before. If the NZUSI is poorly compliant, the filling rate to drop to 10 ml, we should go at slower rate. And if patients are neurogenic patients, a slow filling systometry of 10 ml per hour at most, and filling rate can be increased when the bladder can improve to normal. So I think small steps, important steps, which may lead to a better urodynamic diagnosis so that we can treat. So how do we say, let us say this was a very good paper in Canadian Urological Association Journal, where what they did is they did a urodynamic in patients with nocturia, and they have all male and female patients. And what they just have emphasized what urodynamic findings they have received in such patients with nocturia when they did a urodynamics. So the 3 most common was DO, detrusor overactivity, underactivity, and blood outlet obstruction. They were isolated or can be a combination of both or combination of 3. And this is what they have concluded, that a substantial proportion of adults, whether male or female, presenting with nocturia have underlying detrusor underactivity and overactivity as an underdiagnosed condition. So again, a lot of work need to be done. These are something which are just telling us that what findings we can get if we do a urodynamics in such cases, and patient can be managed accordingly. So I think underactivity is important whenever we suspect underactive bladder based on our clinical history and examination in such patients. Role of urodynamics, I personally feel, is there. It may help us. This was in paper on female patients published in Neurology Urodynamics in 23. And they have studied 596 female patients were included with nocturia and doing a urodynamic study in these patients. And what they have emphasized, that if urodynamic study is done in a proper protocol as per ICS, and what they concluded, that on UDS they have found these female patients with nocturia were more likely to have blood outlet obstruction and dysfunctional voiding. So we have 2 papers specifying 2 different things. One was saying the most important finding in their cohort was DO, DU, and BOO. But in this paper in Neurology Urodynamics, in 596 patients of females, they said BO and DV were really significant findings, and we know both of these are treatable. So we were talking till now, I think whatever we are saying, we all are well versed about conventional urodynamics or video urodynamics in case of neurogenic bladders. I came across a paper of ambulatory urodynamics in these patients. This was published in 2022 in SIU journal. They have analyzed, they have taken 24 patients, those who underwent a conventional urodynamics prior, not able to get a representative study or an answer after aerodynamics. Then these patients underwent an ambulatory aerodynamics overnight, and what they have concluded that 84% of such patients had their clinical diagnosis and subsequent management based on their ambulatory aerodynamics over conventional, and 79% reported an improvement in the urinary symptoms, and all these patients were of primarily nocturia patients. So I'm talking only on nocturia, whatever literature we have received so far. So I think in this paper, what they have emphasized is the role of ambulatory over conventional. If you are not getting an answer on conventional video, ambulatory have a place. And we will understand that DO, definitely ambulatory has an edge, may have an edge, but yes, false DO also can be reported even in a symptomatic patient. This is a weakness or fallacy of ambulatory aerodynamics. So I will basically conclude my talk having some take-home points. See, we are discussing since morning. I should say that urodynamics is not indicated in all nocturia patients, right? Neither all nocturia patient require some sort of a management. We should identify which patient need management and which patient need a evaluation where urodynamic can be a part. We should not try to treat nocturia. I think it's important to treat the underlying condition. Will help us to treat those patient nocturia. And as a urologist, I should say that we should consider non-urological causes also, and we should at least have a suspicion and can refer a patient to our sleep physician. I will happy to share that we were asking some Indian data about this topic since morning, that we at AIM Rishikesh, we did a study, a prospective study on 155 patients, which is published in IJU in this year. And that was on sleep disorders on patients of LUTS. So all the patients of LUTS which were coming to urology OPD, we just added 2 simple questionnaires of Berlin questionnaire and PSQI Pittsburgh sleep quality questionnaire, and try to find out an association between these moderate severe symptoms with sleep. And all these patients were referred to a sleep physician and got a sleep study done. So I think this is a small step what we or urologists can take to initiate with, and bladder diary is definitely very important. And the last slide which I want to say, how to choose our urodynamic. Conventional, yes, we all know. Video guidelines, definitely, if you are suspecting angiogenic bladder or upper tracts damage, definitely video will definitely be the gold standard. And ambulatory, I said that it can have a place if conventional is not representative. And in some young patients, those who are very shy patients, can have some benefit of ambulatory. Thank you so much, and thank you for this opportunity.
Thank you, Dr. Mittal sir, for enlightening us the role of urodynamics in nocturia, and explaining meticulously how we should do in the patient. And thank you, sir. And kindly stay with us. The discussion will be after this next talk. So I would like to invite our next speaker, Dr. Bimal Dixit sir, for the topic what we use in day-to-day practice, that is medical management of nocturia, focus on melatonin. So over to you, Dr. Bimal Dixit sir.
Thank you, and good afternoon to the Uttarakhand and North Zone Urology Society members. My topic today is medical management of nocturia and a special focus on melatonin. As we heard in previous slides, previous lectures, as per definition, if there is at least one void in the night which disturbs the sleep, it's called nocturia. And it becomes clinically significant if there are more than 2 voids. And clinically significant means this causes morbidity. So if we see the prevalence of nocturia, there's a Western study where they studied patients of more than 70 years old, the normal population of more than 70 years old, and they found that more than 60% of population of above 70, there was a prevalence of nocturia, excuse me, and the diagnosis rate out of these was just 26%, and the treatment was taken by just 18%. So why this much fuss about nocturia? Because nocturia causes reduced quality of life, it causes poorer overall and mental health.
it reduces work productivity, it causes increased chances of falls and fractures to the old age population, and can lead to mortality. So as Dr. Pawan also highlighted that we know the sleep cycle, there's an REM sleep, then it goes to REM. So if there's a disturbance in
sorry to disturb, can you please expand the slides to the slideshow mode? They are not moving on the screen.
Oh, sorry, just a second. Are they visible in slide? I mean,
no, you need to click the Control F5.
Control N?
Control F5.
F5.
Oh shit.
Or there is a icon at the bottom. If you see an icon, I think second or third icon on the bottom, just see.
Slideshow
It'll take you to slideshow.
Okay. Okay. So
the bottom line icon, just see.
Just a second. Is it visible?
Now, yes.
Okay, sir. Okay, so as Dr. Pawan told, that if there is any disturbance in the NREM sleep, that is in the first few hours of the sleep, so that deep slow wave restorative sleep occurs during the first few hours, while less restorative sleep, that is lighter sleep, is pronounced later. So if waking occurs in the first 3 or 4 hours, this is more likely to leave a person tired next day and hampers the work hours. Okay, so this nocturia just don't affect the person, this also affect the family members and cause dispute. Now, if we see on this slide, if we compare the person who are waking up more than two times, that is clinically significant nocturia, they have lesser survival probability than the person who are waking less than 2 times in the night for nocturia. So now comes the point whether the nocturia, if it is not bothersome, should we treat or not? So we have found that association of nocturia with mortality. So this is not dependent on the bother of the nocturia, because sometimes what happens, nocturia is a sign of other systemic diseases. So if we evaluate that patient who is not bothered with the nocturia, we find some hidden diseases which can be treated with and which can delay the morbidity and mortality of that person. So for any treatment, we need to classify a particular disease, and the basic tool for nocturia is a frequency volume chart. We can see that with frequency volume chart, we can classify nocturia in 3 major groups, that is global polyuria, second is impaired or diminished bladder capacity, and third is nocturnal polyuria. So the causes for these three groups are, as can be seen in this slide. For global polyuria, this can be primary polydipsia, diabetes mellitus, diabetes insipidus. For nocturnal polyuria, the causes are listed, and the same for bladder storage disorder. Now, the treatment can be symptoms related. Like if patient has got prostatic problem, we can treat prostate. If patient has got OAB, we can treat that. If patient has got sleep disorder, we can treat the sleep disorder. If this is nocturnal polyuria, we can treat the cause of nocturnal polyuria. So for nocturnal polyuria, we need to focus what is causing it. So if there is overconsumption, that is we can treat with the behavioral therapy. We can if there is DI, that is insipidus, we can treat that. If this is because of diabetes mellitus, we can treat that particular disease. If this is over diuresis, the cause is over diuresis, like a third space like pedal edema, we can treat accordingly. Like if there is CHF, renal condition, diabetes mellitus, we can treat that. And if there is little antidiuresis, like the cause is circadian failure, there are other conditions we can treat depending on the particular cause. So as per the cause, we can direct the treatment. Now, since we are urologists, we focus on the lower urinary tract dysfunctions, And mostly if patient comes to us for nocturia, we start with alpha blocker, anti-muscarinic, or mostly focusing on the lower urinary tract dysfunction. But we must consider that this may or may not be the only reason for nocturia. Now, the goal for treatment should not always be complete cure. Even if we decrease the disease with 50%, that is voids, if we can restrict it to 1 or 2 just, then we can achieve this goal. So depending on the severity, we can set our goal. Now, the first and foremost treatment for the nocturia is lifestyle change. For lifestyle change, what we can do, we can restrict depending on the problems. Like if patient is taking too much fluid, we can restrict it to up to less than 2 liters, or 20%, 5% less than what he was taking before, so that the amount of urine production is reduced. Secondly, we can restrict afternoon or late evening fluid intake. And so if we summarize, so if patient, we can ask patient to go same time to the bed, so that his or her circadian rhythm is maintained, maintain a good temperature so that he can go into sleep easily. Should stop multimedia time or social media time. Secondly, he can restrict his diuretic medication in the night or in the evening. He should take it at least 6 hours before going to bedtime, so that whatever action of diuresis is going to anti-diuresis diuretic medicine like Lasix and Lacilactone is going to happen, should happen before sleep. Secondly, if he or she is having edema in the lower limbs, he or she can wear stockings, or can elevate his or her legs while sitting. Now, in summary, we can ask patient for preemptive voiding. This is before going to bed, he or she should pass urine. Nocturnal and late afternoon dehydration, that is, should not take significant amount of fluids before going to bed. Should have dietary restrictions like caffeine and alcohol. The medication timing, that is Lasix and Lacilactone, Diator, these medicines should be taken in the afternoon only. There should be use of compression stockings if there is pedal edema, and the legs should be elevated if patient is has prolonged sitting in the evening. In the pharmacotherapies, we direct accordingly. Like if patient has got overactive bladders, we can treat that prostatic enlargement in the same phase. Now, starting with the medical treatment, the available therapies are, number one is desmopressin. The desmopressin, as we all know, can treat central diabetes mellitus. If it is peripheral, that is the fault is in the collecting tubule or distal convoluted tubule, then it may not help, because we know the desmopressin act on the distal convoluted tubule or the collecting duct. So if patient has got central diabetes mellitus, central DI, or there is less production of desmopressin, then probably this medicine will help better. Now, prior to initiating desmopressin, because this has got some contraindications also. So prior to initiating this treatment, we need to monitor sodium levels, because this restrict the water excretion. So dilution or hyponatremia is a chance that patient may start getting this. So before initiating, we need to measure sodium levels. Within 7 days of starting treatment, we need to measure, and then accordingly, like after 1 month, or if we are adjusting any dose, then and then periodically. Because in patients who are above 65 years of age, there are increased chances of hypernatremia, which can lead to further deterioration of health. So sodium level monitoring is important. And as per the different studies, the desmopressin has a proven role in reducing nocturnal polyuria. Now, the important in desmopressin is we need to minimize the risk of hyponatremia, and we need to restrict its action if possible, especially in the night hours. For that, there's a one solution for this problem, that we have got intranasal desmopressin available in India also. This Noctiva is available in Western countries. In India, This is a different name, and we have got intranasal desmopressin. This delivers at least 150 microgram of dose when given intranasally. And the good part is that it has got no depot effect. Secondly, it has got consistent absorption. So we can restrict if we give tablet form or other forms, then there are chances of hyponatremia, which we can restrict with the use of intranasal desmopressin. The good part of intranasal desmopressin is that has got high bioavailability. The peak plasma concentration is in control. There's shorter duration of action, and easy to use. The contraindication to the, as we discussed before, also the significant part one is dilutional hyponatremia. Others are like congestive heart failure, uncontrolled hypertension. There are chances of fluid retention, and there are chances of nasal stuffiness. So we need to check these things, that patient should not have any underlying disease like congestive heart failure or hypertension, which can worsen because of this use. Now coming to melatonin, previous speakers also discussed about melatonin, and we know that melatonin basically controls the circadian rhythm. So this controls the synchronism between the central and peripheral pathways. The central pathway is suprachiasmatic nucleus and the hypothalamus, and peripheral pathways are in the different organs. One we are discussing today here is urinary bladder. So bladder has got many types of gap junctions and ion channels, which are on detrusor and urothelium. And this melatonin basically make a synchronism between the peripheral organs and the central nervous system. So this basically is produced from the pineal gland, pinealocyte, and its production is mainly in the dark hours, that is while we sleep. So this act through the melatonin 1 and melatonin 2 receptors, and these receptors they are basically expressed in both central and peripheral organs and central nervous system. And this basically helps by inhibiting the receptors on the detrusor muscle. So mucous and muscular receptors, they are inhibited. So in the night, if there is contraction because of increasing in the volume of the bladder, so melatonin inhibits that contraction. So if we can classify, this has got central inhibitory effects. This has got peripheral effects by reducing the contractility of the bladder, by reducing bladder afferent mechanosensitivity, and other antioxidative effects. So with age, there's a reduction in the level of melatonin, and there's reduction in the synchronization of peripheral and central nervous system. So that can be restored if there's reduction in the level of melatonin. There are few papers, although FDA has not approved exactly melatonin for the treatment of nocturia, but and this melatonin comes in the dietary supplements. So the proven role of nocturia for melatonin for the nocturia is not there, but there are few papers which establish that melatonin can have good effect on the nocturia. There's one paper in 2023 in the autonomic neurosciences. This says that the nocturia developed mainly in the elderly and could be caused because of defect in the circadian rhythm. So here, if we give melatonin, patient may get benefit with the nocturia. There's another paper which the study was done in Thailand on the 60 women, and they found that melatonin has got good effect to control nocturia. There's one other paper where this says that it is better than placebo. Melatonin treatment is associated with significant nocturia response rate and improvement in nocturia-related bother and a good adverse effect profile. There's one more paper where the melatonin or the substitute of melatonin, that is rilmafazone, this is used, and they found that it had got good effect. Now, what the side effect of melatonin are not significant. There are mild side effect of headache, nausea, dizziness, and drowsiness. The duration also is, if we take a melatonin tablet, it takes around 30 to 40 minutes to act. Peak level come in 1 hour, and then level goes down in 4 to 8 hours. And these are important because the NREM sleep is important in first 4 to 8 hours. So this melatonin is good for maintaining NREM sleep. And this can be given in preschool age, school age, or adolescent girls. The safety is not proven for the pregnant or breastfeeding. It can cause harmful interaction with other antihypertensives. Should be, I mean, we should be cautious. Should not be given a person who are driving, and this is not under FDA control. So before this, I just want to say that melatonin available freely in India with the name of Melosoft by Aristo Pharma. And this is given as a food supplement, and this has got good effect. But important is that we should first find out the cause of nocturia. If nocturia is due to lower urinary tract dysfunction, we can treat. We urologists know very well about a lower urinary tract, and we can treat that to treat nocturia. But if nocturia is not due to lower urinary tract dysfunction, it's because of some systemic disease. So we need to find out that systemic disease, or due to some lifestyle problem, we need to find out that. And melatonin or desmopressin should only be given to the patients who are not affected by lower urinary tract dysfunction. So the cause finding is important, and then after cause finding, we need to treat. And melatonin or desmopressin should not be used I mean, at the last resort, like if nothing is working, we can give these medicine. No, these medicine can only help if patient has got problem pertaining to a disease which can be treated by these medicine. Thank you very much.
Thank you, Dr. Dikshit, for the step-wise presentation for the management of nocturia, and also evidence-based management of desmopressin. It's a one of the very crucial stage. Sometimes we are very confused. Should we use melatonin? Should not use? Thank you. And now the session is open for the discussion. Over to chairpersons.
Yeah. I have two questions actually. One for Dr. Ankur and one for Dr. Vimal. Yeah. Hello.
Yes.
Yeah. So for Ankur, I think Ankur said that urodynamics has a role in OSA. I just wanted to ask, how does this urodynamics will change the treatment of OSA? What things will it add to the treatment of OSA? And to Dr. Vimal, my question is, like, should urologists be prescribing melatonin? If yes, then which is the subset of patients where we should consider prescribing melatonin?
So let me take the first question. So see, what I discussed was that if we are, as a urologist, let us say the patient of LUTS comes to us in our OPD, and we suspect that, okay, we have done an evaluation and we found that there is no urological cause, and we are suspecting a sleep cause to be the cause of his or her LUTS. Now, for this sleep cause, patient is diagnosed as OSA by sleep physician, right? So basically, the role of urodynamics, how it will help, there is no proven right now. There is no literature that whether treatment of LUTS, effect of treatment of LUTS on OSA or effect of treatment of OSA on LUTS. So the paper which I presented was that all those patients, those who were diagnosed OSA cases, they did it. So the findings were there, but that findings were reciprocated when they were treated for OSA by CPAP. So it was just a finding and association, not an answer that there is a role of urodynamics in those cases. It was just a finding that if you do urodynamics in those cases, you can get these findings. But these findings were reciprocated when they were treated for OSA as a CPAP, not by for management of LUTS. So just a association study, not a correlation study.
Okay. So sir, your mic is mute. Dr. Vijay, your mic is mute.
Oh, sorry. So I was just, so in the end, what you want to say is that in OSA, we need not do urodynamics in each and every patient. Obviously, there will be findings, urodynamic findings, but that will not add on to the treatment of the primary treatment of OSA lies with the sleep physician.
Exactly. So the message is very clear. As a urologist, we need to suspect cases because the patient will come to us primarily. So, and refer them to proper location.
So now, as sir, you asked the melatonin treatment with the melatonin. So as I discussed in my lecture, nocturia should be first discussed in a whole. What is the cause of nocturia? Because we urologists always, if any patient comes to us in a old age or young age, if he says nocturia, we first think this is because of lower LUTD. There's a lower urinary tract dysfunction, and we start treating whether prostate or anything. We first medicine we give is solodocin. So my point is, first and foremost is we must check nocturia, because we evaluate once patient visit again and again. I mean, he was seen every second, third day in the OPD. Then we see, oh, something is wrong. We are treating something wrong. So my point is, first we should check what is causing nocturia. If this is LUTD, then we go ahead with the treatment what we know better. But if nocturia is not because of that, it's nocturia because of some systemic disease. If nocturia is nocturnal polyuria or global polyuria, we need to treat that. Role of melatonin come in patient who have got circadian rhythm disturbances. Although today we don't have in Dehradun, but in Delhi and in other metro cities, we have a saliva test, urine test, blood test for the level of melatonin, where the major labs like Radcliffe and other labs, they test the level of melatonin, and we can find out. Secondly, melatonin can be given for 1 or 2 weeks therapy without any significant concern. Like a patient, if he is frequent waking up in the elderly age group, or even in young patient also, they may have disturbance in circadian rhythm, that like who are traveling in, like having jet lag, traveling with air and all those things. So melatonin.
Dr. Mil, my point is like, should we be treating that, or should we it is better referring it to a sleep physician who's a better person suited to prescribe melatonin, rather than us identifying and then referring the patient or treating with melatonin? That is my point.
Sir, melatonin treatment, actually this comes in the food supplement thing. This is not a medical treatment. So melatonin treatment can be given by either, but thing is that for nocturia we need to identify, because patient with nocturia will come to urologist first. If he or she knows that urology is the thing, then so we need to isolate that patient. This patient has got circadian rhythm disturbances, and we need to treat circadian rhythm disturbances. We can give, because this is a food supplement drug, melatonin can be given by physician, general physician, urologist, cardiologist. But we need to find out that this patient does not have any systemic problem for which, like for systemic, like patient needs to be treated by physician, by cardiologist, by pulmonologist. So we need to isolate and categorize. If sleep disturbances, I mean, if this is because of circadian rhythm disturbances, we can treat by ourselves, or we can refer him or her to physician.
No, but what is the official recommendation on this?
Sir,
that is what I wanted to ask. Whether are we suited to prescribe melatonin?
I mean, sir, if you say there's one term called geriatric medicine, where these are kind of general physicians who are specialized in geriatric medicine, and they give this kind of therapy. But this is not a specialized thing. Specialized thing is that we need to I mean, segregate this patient in which category he or she fits, and then we can treat. So we can refer him or her to geriatric specialist if available. Or if we send him or her to general physician, he will be again beating around bushes, will not be get treatment.
Vivek, sir, can I chip in?
Yes, please.
Yeah. So, Dr. Vivek, I think Vivek and Dr. Kulkarni both are asking one thing, a message for us as a urologist to our youngster, that I think the message is very clear from our presentation, that we are here to rule out urological cause, treat them. We are here to rule out other causes of nocturia, because patients are coming to us with our understanding of the subject which we have gained today. But if we are getting an understanding that this is not related to urology, I think it's better to send it to, because the sleep physicians, see, I will give you one example where we are using in collaboration with psychiatry or sleep physician, the patient, those who are standing long in the ward due to XYZ reasons. They are sleeping in the daytime and they are awake at the night time, right? And this cycle disturbance, now they understand whether they require a lorazepam, whether they require alprazolam, whether they require a clonazepam, or whether they require melatonin. I think that there is a lot of things to be understood by that specialty. I personally feel I think they should chip in and the patient should be referred to the specialty.
I
That is
totally
what.
agree.
When I see some of these patients being referred from the neurology, neuropsychiatry group, they are referred for the management of lower urinary tract symptoms to us actually. They are themselves not tuned to the idea of using these medications for the treatment of lower urinary tract symptoms, and these experts, neurological experts or the psychiatrical experts, are actually referring these patients to us. So as a urologist, we need to know the pathophysiology behind the development of these LUTs in these patients before we prescribe this medicine. And I don't think there is any harm in a urologist prescribing melatonin, provided the indication is confirmed beforehand, and all other factors are ruled out.
I fully agree with Dr. Rishi. In fact, we should, any patient of nocturia, we should be the primary physician for patient, because if the patient is started, like many of our physicians, they start solifenacin straightforward without asking or looking for even post-void residue, or if he or she has any other problem. So what I think, whatever Dr. Rishi, I agree with him that primary physician should be a urologist. We should evaluate and either confirm or exclude any urological cause. If it is there, it can be taken care of. If it is not there, then yes, we can start melatonin. It is not that toxic or something very serious kind of drug which it cannot be prescribed by a urologist.
So my point to add here is just one thing, that since nocturia patient will come to us first, we need to segregate this thing, that if patient has got some systemic disease, we need to refer him. Obviously the cardiologist will treat better, physician or pulmonologist will treat better, but we have to make patient tell him that he need to go to this particular person. Otherwise he will keep on running to different OPDs and will not get proper treatment. So we can deal with nocturia and classification. Yes.
My thinking is that it will depend on where you are working. If you are working in a tertiary institute, then it is better to refer and get a suggestion and consultation from the other department, like the sleep specialist, because sleep is a very big department and it's a very important thing. But if you are in a smaller place where you do not have people who are looking after the sleep part and these that psychological counseling and other things, it is better to give melatonin. And if I am in practice, then I will give melatonin if it is not a case of other department like sleep apnea and other things. And if you feel that it's only a urological cause and where you can use melatonin as the tertiary drug, you can use it.
If I
have
can
a
say,
different view.
Depends
I
upon
think we should
what are
stick
the
to the
primary
treatment. Yeah.
complaints of patient. Sorry.
So we
Sorry,
need
Dr.
to-
Pawan. Carry on.
So I,
move on, maybe a
so I
quick
think
comment.
I think if a urologist has ruled out a urological cause, then the first thing that needs to happen is that he goes to a cardiologist, respiratory physician, and a sleep person. Only
Yes.
after that can you be even thinking about melatonin, which I personally feel should not be in the domain of a urologist. But at least before we reach, I mean, it cannot be that we ruled out our portion and because it is harmless, then we start melatonin. That is not the stage to be looking at melatonin.
May I
I
make
think
one?
I agree with Dr. Pawan that I think the urologist should be limited to identifying and treating the urological causes of nocturia and referring the patient, if any other cause is found, to the concerned specialty or to the concerned specialist. That is my take on it.
I think message very clear from the house. If baby belong to us, please treat. Otherwise, refer. What I
Important
think.
is
Evaluate
diagnosis.
and treat. Otherwise, refer.
Important is diagnosis. Nocturia should be diagnosed first. Who is going to treat?
Correct.
Diagnosis is important, and we
diagnose,
should diagnose
evaluate,
it.
and just it belongs to us.
Let me emphasize it that it is not that who is treating what. What is our management should be patient centric. If patient is having only problem of nocturia, he doesn't have a sleep problem, he doesn't have any other thing, then I think for nocturia, urologist is the first person to take care of it. If there is any associated problem, we can take advice of our friends, but primarily any patient of nocturia should remain with the urologist only, because we can manage them properly.
So
If I am not wrong.
So there was an article in European Urology where the caption was Nocturia is whose baby? I mean, who is going to own Nocturia? So it is all right that the urologist coordinates everything, but it is not all right that the urologist starts prescribing on behalf of the others. I mean, urologists can stay maybe as the nodal point while others are being coordinated, and you've ruled out the urology issues. But urologists prescribing sleep related medicines or melatonin, I'm not sure. Dr. Sanjay.
Point well taken, sir. I think it is your opinion is absolutely fine, sir.
Sir,
We agree on that.
Actually now.
Yeah, actually, we are running at the time.
Move on to the next one.
Yeah, correct, sir.
I think, Dr. Rishi, we should move to next part of our session, because we are already very late.
Thank you. Yes, sir. We are just out of time. I think 5 minutes late.
These same questions are going to pop up during the discussions also, I'm sure. So for the discussion part, Dr. Hemant is going to present some real case scenarios, and the discussion would be with the panelists, Dr. Sanjay Goyal, Dr. Rajesh Taneja, Dr. Tanuj, Dr. Sanjay Sinha, and Dr. Santosh Kumar. Keep your videos on, and as and when required, you can mute or unmute your mics. Dr. Hemant.
Yeah, thank you, sir. Hopefully, my voice is audible.
Yes, yes.
Yes, sir, you're audible.
Thank you, sir. Thank you. And this is a great time because Northern has taken this activity and having very important discussion on nocturia, very important topic, but less discussed. So a lot of discussion was going on, and just I would like to have my take on that is the urologist is a bit funny surgical branch because most of our super specialty, they are called plastic surgeon, neurosurgeon, and pediatric surgeon, but we are not called urosurgeon, we are urologist. So there is a percentage of physician and surgeon within us. We are in OPD urophysicians, and in OT we are urosurgeons. So the management of nocturia depends how much physician is within us and how much surgeon is within us. When we have a lot of urosurgeon within us, then the management of nocturia is difficult. So here we have to be a lot of urophysicians. So with this, and panelists with me are Dr. Sanjay Goyal, Dr. Rajesh Taneja, Tanuj Paul Bhatia sir, Dr. Sanjay Sinha sir, and Dr. Santosh. So I'll start some real life case presentation. So with permission, can I start?
Please go ahead.
Yeah. So this was a 60-year-old male with 6-month history of nocturia, 5 to 6 times, urgency frequency. There was a decreased frequency of urinary stream and a sensation of incomplete bladder emptying. These symptoms have progressively worsened over last few months. Just a minute. Yeah. So these symptoms have progressively worsened over last few months and leading to disturbed sleep and daytime fatigue. Medical history, he was a hypertensive, which was controlled on medication. There was no history of diabetes, and he was non-smoker. Clinical finding per abdomen and local examination were normal. DRE revealed a grade 2 prostate, smooth, non-tender. IPSS score was 22. On investigation, urine analysis was normal. Serum PSA was 2.9. We asked him to have a bladder diary for 3 days, which is standard protocol. Maximum voided volume was 280 ml. Total intake 1800 ml. Average total intake was 1800 ml. Average urinary volume per day, including night, was 1500 ml. Daytime frequency of 6 to 7 times. Nocturia 5 to 6 times. And nocturnal output was around 25%. So my first question will be to Dr. Sanjay Goyal, sir. Sir, how will you proceed in this case?
First, I would like to know what antihypertensive drug he is taking.
He was taking amlodipine H. That
H.
was, yes.
That's a diuretic.
Yes.
Okay. And what are the further investigations like ultrasound and uroflowmetry?
So this was his uroflowmetry. Uroflowmetry, Qmax was 8.4, Q average was 4.6, voided volume was 170 cc, and PVR was 90 ml. Ultrasound was urinary bladder was thick wall, pre-void was 330 cc, PVR was 110 cc, and prostate was 44 cc with some median lobe hypertrophy.
Okay.
So, sir, how will you start the management of this patient?
First thing is that I would like physician to change the antidiuretic along with in the treatment of hypertension.
So we will have a cardiology review.
That is the
and
first thing.
If they can
Yeah, I will
change.
suggest him that you switch over to a antihypertensive which doesn't have a diuretic.
Okay, sir. So after
That will be
that
the
is.
first step.
Hmm.
And the second step is because his Qmax is quite low and Q average is also low, his PVR is also significant, 90 ml. So I'll be keeping that patient as a first go on the alpha blockers. And I prefer especially the silodosin.
Okay, so it will be alone or in combination of something. A dutasteride you would like to add at this point of time?
No, I will
PSA
go back to what is the size of the prostate? What is the?
It was 44 gram was the size of the prostate and PSA
No,
was
I will
2.
continue. Yeah, I will start with the silodosin.
Okay. Dr. Rajesh Taneja, any you go with the same opinion or any change in investigation or initial treatment?
This is fine. This is quite an obstructed prostate, quite an obstructed bladder with a small functional capacity. And I would prefer to add with silodosin, of course, mirabegron, because his Qmax, although is 8.4 and residual urine is 90, but he may just turn around with his symptoms. But eventually, he's a young man. 68 is young today, and he has no serious comorbidities. He's going to live long, so he will perhaps eventually require a TURP or a surgery for his BPH. Because his residual urine is significant, we have more than one indication for surgical intervention in him. But before that, we must give him a good trial of medical management. At 44, it is questionable whether to add dutasteride or not. But we will just go without dutasteride. We'll start with silodosin, and I will add mirabegron. And maybe even if somebody advises him surgery and he goes for it, he must be advised that since his functional bladder capacity is not too good, even after surgical intervention and TURP, his frequency or nocturia may reduce but will not go away.
So, Dr. Sanjay Sinha, sir, so one opinion is to start with silodosin. One opinion is to add mirabegron to silodosin. Will you add any lifestyle modification in this patient? And what will be your line of treatment, initial treatment?
So let me start with a comment. This patient has a dramatic difference between the mean voided volume in the day and the night. Because from what you've told us, this patient passes 1500 ml over 24 hours, 6 to 7 in the day, 5 to 6 in the night, and yet passes 25% of the volume in the night. So the mean voided volume at night is dramatically lower than the mean voided volume in the day, which is the reverse of what we expect, even for a patient who has nocturnal polyuria otherwise. So typically we expect mean voided volumes to be higher in the night. So something tells me for some reason he's not sleeping well, because it's very unlikely that urgency will cause a lower mean voided volume at night than in day, and such a dramatic difference. So that's just a comment from the case stem that you have given us. I agree in general with whatever Rajesh has just said, that this patient requires management. I think this patient clearly has a poor flow. And regardless of whether storage or voiding dominates, in such a patient, I would ordinarily start an alpha blocker. Usually along with that, with an OAB drug, and mirabegron is fine in such a setting for a patient who has substantial urgency. So I'm assuming he's got urgency dominant, or at least urgency as bothersome as the voiding problem here. And I would actually be comfortable starting both. And as I said, address what's the issue at night, because something else is bothering this patient at night. And if you don't take care of that, you might do a TUR, have a good flow, and still have a patient who is not comfortable. And that happens once in a while. because something is causing this patient to wake up, and he'll continue waking up after a TURP.
So what extra would you like to do for this evaluation? For this?
No, so what I mean to say is that whatever case history we have, that is not capturing the nighttime frequency, why that's happening. Because why on earth would he be passing 150 ml each time in the day and pass 60 ml or 50 ml at night each time? There's no reason for that. The other way around is possible.
Yes.
This is an unusual pattern, is all I'm trying to say. So what I'm saying is there's something else that is bothering this patient, and not all can be explained just by urology.
So basically, we
have a patient. So sorry.
I think it is because of the diuretic he's taking in the morning.
No, but if that would happen, it wouldn't cause the mean voided volume to go down. You're missing the point. The mean voided volume at night is much lesser. I'm not talking about frequency.
Very valid point, that we have to calculate not only how much time getting them in the night, but a mean voided volume.
Just go back one slide.
One of the things.
See this.
One of the things is
night time 5 to 6 times, daytime 6 to 7. 75%.
So that is the importance of bladder diary, sir. Your this observation is very valid, because the patient is, the mean voided volume is almost half of, or less than half of what he is avoiding on an average in day. So probably he has some sleep disorder, which is adding to his and some LUTS component. So LUTS
there is another
change will not change this.
Yeah, there's another thing we must inquire. If he's having something like a cup of coffee at night, or if he is having some irritant to the bladder, maybe an adrak wali chai or masala tea, which can irritate the bladder at night, and even if it is a low volume, he's waking up at low volume to pass urine.
So usually most of them, Rajesh, would also cause some concomitant diuresis. If somebody takes coffee, for instance, or tea or alcohol, usually the volumes will also go up. So his
something that is irritating
urine volume is low. Anyway, I mean, so let's not get into the split hairs.
Yeah.
All I wanted to say was there's something else bothering the patient, and it's important to capture that before you operate.
Just keep that in mind.
Otherwise, I agree, in a patient like this, poor flow, if he's refractory, then surgery should definitely be on the cards, because surgery has the potential of giving a long-term solution to both the voiding and the storage.
So the takeaway message was that at least we can prognosticate the patient that we'll start the treatment, but the chances of improvement of the nocturnal symptoms are plus minus. Not that we are not very optimistic that it will improve as much as his daytime symptoms will improve. So the patient was initially advised on lifestyle modification, reducing evening fluid intake, avoiding caffeine and alcohol before bedtime, and he can do double voiding. And he was started on alpha-1, basically psilocybin plus dutasteride combination. My question is to Dr. Tanuj Paul, sir, that what is your apprehension? When will you not add anticholinergic or mirabagrone to this treatment? Like in this case, we were thinking of adding mirabagrone, but in which scenario you will not add as your first line treatment in management of LUTS with nocturia?
I would do exactly what you have done. I would generally start with the alpha blocker and see how the patient is responding. Some of them will respond well even to the overactivity symptoms. Regarding starting anticholinergic and mirabagrone, yes, anticholinergic, we have to be very, especially with he has a borderline PVR of about 100 ml. So I would be wary. Generally in my practice also, I would not start anticholinergics for anybody who has a PVR more than 100 ml. Mirabagrone, again, his blood pressure is well controlled, but still we have to be a little cautious. If the patient is responding well to a alpha blocker, we might continue same. If his obstructive symptoms improve and the storage symptoms and the nocturnal symptoms persist, then we might add something. Of course, all the lifestyle measures have to be done, and coffee at night might keep him awake also. So another reason for not being able to sleep properly. So those things also need to be looked into. Nowadays, a lot of people are having green tea and all those newer things. So I think we should take all that history as well in these patients.
So again, Dr. Santosh sir, any difference of view on any opinion about the treatment or intervention so far? I think Dr. Santosh sir is not there. So we started the patient on alpha blocker plus dutasteride, and at 1 month follow-up visit, the patient had a notable improvement in his daytime symptoms, and nocturia also reduced to 2 to 3 times per night. His IPSS there was also improvement in IPSS score. Euroflowmetry, repeat euroflowmetry was improved with a Qmax of 12, Q average of 7.4, voided volume of 200 cc, and PVR of 40 cc. Now, patient is basically he has reported improved quality of life and satisfaction. At his 3-month visit, patient was more concerned about his nocturia, which was 2 to 3 times per night. So again, Dr. Taneja sir, what is the next? How will you further augment the treatment? What is the next line of management? Now, how will you go about it?
So this is the time when I will again ask for a fresh frequency volume chart. We need to understand, is he producing more urine at night now, or there is something else? And we will now dwell into more of his sleep history, because we know that at 12 peak flow rate, he is certainly much less obstructed than what he was when we started with. And there is no urgency to switch over to an aggressive treatment on the prostate front. So let us look at other things, like something like if he's having something at night, increasing fluid, is he increasing fluid intake at night or in the evening? And certainly look at whether he has been snoring. Does he have OSA or something like that? But you have to find out, maybe on examination when he walks into your room, in your chamber, you may just find that out.
So one thing is sure, we have to reevaluate the patient. The baseline treatment was okay with the alpha blocker. Reevaluation, the most important thing is a bladder diary, which has to be done. And Dr. Sanjay Sinha sir, in bladder diary, what thing you will specifically want to see, like now for his further management?
So actually, in fact, to be honest, at this point, I don't really need another blood. I mean, it would be good to have it, but I have almost all the information I need from the first diary, because I don't expect that there's a sudden dramatic change from that. So this patient does not have large urine volumes at night, has a small mean voided volume at night, and having a bladder diary will probably reconfirm the same findings. So essentially, my approach would be different depending on whether he has zero daytime storage symptoms or whether he has a little bit of daytime storage symptoms. If he has a little bit of daytime storage symptoms, which is likely because his daytime frequency is also a little bit on the higher side, then in that case, I would put him on mirabegron at this point, or even an antimuscarinic should be fine at this point. And the odds are if there would be an improvement in both day and nighttime symptoms with this. But improvement in symptoms with nocturia is modest, was what you expect. If this patient has exclusively nighttime symptoms and no daytime symptoms at all, my policy in such a setting usually would be, and assuming I've ruled other things out, would be to give a short-acting antimuscarinic at the night. So giving something like tolterodine 1 milligram in instant release instead of a sustained release at night. I'm assuming everything else is looked into, of course.
Okay.
So Sanjay, I would like to say that we need a bladder diary again, because his nocturia is reduced from 4 to 5 to 2 to 3.
Sure.
So we need to know what is the maximum voided volume at night.
Yeah.
Because if his bladder is still behaving well, only then we go to the extra urology.
Oh yes, absolutely. Agree. Point taken.
I mean, like in my experience, I can be sure that it depends on the patient. If he's very aware and he can tell his symptoms that he has some daytime storage LUTS also, which he's not concerned. He's concerned about nocturnal symptoms. So there is some daytime storage also. So we can avoid bladder diary and we can start with a mirabegron or a small or something what Dr. Sanjay Sinha sir has suggested. But if we are not
sulfenacin can be added.
Yeah, if we are not able to extract that history, a bladder diary can be a subjective evaluation that he has increased daytime frequency, and then so if it is a daytime frequency, increased daytime storage symptom plus nocturnal symptom, we'll add a anticholinergic. If there is only isolated nocturnal symptoms, so now how will you proceed, Dr. Sanjay Goyal sir? Supposing
that is the time probably we can. One thing probably we have not done, we have not changed the antihypertensive.
No, sir, that has been done. That has been done. He has changed. He has consulted cardiologist. He has changed it. So that lifestyle
Okay,
modification.
despite antimuscarinic, if the response is not there, it is the time when we can definitely add some desmopressin, and we can see whether it can reduce the nocturnal frequency or not.
No, no, sir. I'm asking that if there is no daytime symptoms, there is no daytime symptoms on voiding diary also, the frequency is okay. He has only nocturnal symptoms. On his bladder diary
So for
also
that you will have to, yeah, for that you will have to have that desmopressin.
So any further evaluation we would like to do, Dr. Tanu sir, you will like to do any further evaluation in this patient, or we'll just add the next medicine in our armamentarium?
If with the component of his nocturia, there is an element of urgency, and I would like to do a urodynamic study to actually understand what his bladder is, what is happening there.
Dr.
Or
Sanjay
this,
Sinha, sir?
So I would ordinarily reserve invasive evaluation for invasive therapy. So if we are at a juncture where the patient is considering surgical options, then it's reasonable in a patient who has substantial storage or dominant storage symptoms. If right now I'm planning for medical management, which seems to be the case at this point, then I probably wouldn't do a urodynamics. I'm assuming that this patient has, again, relatively small nighttime evoided volumes, and the patient has not suddenly developed nocturnal polyuria, which was not there to start with. So if this patient doesn't have nocturnal polyuria, getting up 2-3 times, obviously the bladder is not holding well. And I ordinarily would not be prescribing desmopressin in such a situation, because the patient doesn't not have nocturnal polyuria. Then the return for using desmopressin is not that high, and desmopressin carries a small but serious complication rate. So patients can have asymptomatic drop in their sodium levels and suddenly present with florid symptoms, and that can happen unpredictably in the long run.
So I think what message I have got is, at this point of time, a good history to evaluate daytime symptoms with addition of bladder diary will help in our further management. We can have cross-reference our cardiologist opinion. We can optimize his other medicine which is going on, and cautious use of urodynamic. We are suspecting it is because of lower urinary tract symptoms, so we can add on mirabegron or other anticholinergics. If they are not beneficial, then we may consider desmopressin. So
there are a couple of questions in the chat box, and I just thought important to respond to them, that surgery is absolutely on the table. So if this patient is having any element of voiding problems despite the alpha blocker, there really is not much additional benefit you expect even after 3 months with the 5-ARI. In somebody's prostate size is not much. So if he's bothered by voiding difficulty despite the alpha blocker, the odds are if you do a TURP on him, both the storage and voiding symptoms will reliably improve long term. There's about a 60 to 70% odds of a long-term resolution of storage as well. So definitely surgery is on the cards. And in that point setting, maybe what Tanush talked about, doing a urodynamics, if the patient has storage dominant symptoms, is a reasonable option. Sorry, go ahead.
At this point of time, when he's not having that much avoiding lower urinary tract symptoms, at this point of time, is surgery will be beneficial over and above what we are doing? At this point of time, like after the patient.
I don't think he is already satisfied. He is not bothered about the obstructive symptom. He is bothered about the nocturnal symptoms at present.
Agreed, sir. That is one of the
I don't
things.
think it is the right time to go in for surgery.
But that is, if he is not responding to anything at all and does have a predominant storage symptom, which he might be suppressing during the day, then urodynamic also gives us a hint whether he'll respond to surgery or not. Because if you have the terminal overactivity, that means he will have a good result with the surgery.
Maybe, yeah.
So, sir, I think if patient is satisfied, we can continue with medical treatment. But if he is unwilling to take the side effects of desmopressin, or he is having side effect of medical management, then we can
Then he has to go for surgery.
role of urodynamic, whether the surgery will help, and we can proceed with surgery also. I think that is the way to go in this case. So otherwise, if he's satisfied, there's no side effect for medical management, we can go ahead with the medical management. So this case highlights the typical presentation and management of nocturia, which we most commonly encounter in our OPD. Nocturia in the context of BPH is thought to result from a combination of obstructive and irritative symptom leading to decreased bladder capacity and increased nighttime urine production. Now I'll just one more case I'll discuss. So this was a 50, actually the first case was a real life case, but the second case is a case of nocturnal polyuria. So we'll have some discussion about how to investigate and go about the treatment of this case. It was a 45-year-old male with a 9-month history of nocturia, 5 to 6 times, disrupting his sleep, and he had having daytime lethargy and daytime symptoms also. He is not complaining of any voiding LUTS. There is no comorbidities. His BMI is normal. Examination is grossly normal. Digital rectal examination was normal. Grade 1 prostate, firm, non-tender. Urine analysis was normal. Serum electrolytes and kidney function test is also normal. Uroflowmetry is grossly normal. It is Umax is 60 ml per second. Q average is around 8.7. Voided volume was 200 cc and PVR was 10 cc. Ultrasound is also normal with a prostate volume of 18 cc and there is a negligible PVR. Bladder diary was made where there was a maximum voided volume of 300 ml. Total intake was 2.5 to 3 liter. Total urine volume is around 2.3 liter. Nocturnal urine volume is around 1 liter. And there are 5 to 6 episodes of nocturnal voiding. So conclusion of nocturnal polyuria was made. So Dr. Rajesh Tinaja sir, how will you now, any further evaluation or how will you start the treatment of the patient?
See, the thing is, I would rather say that if he's getting up 5 to 6 times to void 1 liter of urine, he still has a small functional bladder capacity. If you look at his ultrasound and look at his voided volume during uroflowmetry, this is not normal. Normally, you should have something like at 45 years, you would have a functional bladder capacity of 500 plus. Here is a person on 2 occasions, he has 200, 250 on ultrasound and 300 on his frequency volume chart, which means that yes, that his functional capacity is somehow small. So we need to look at that. Is it the irritated urinary bladder because of something that he is consuming? Or we will have to work on, does he wake up at night with pain or does he wake up at night with full bladder sensation? Because there is something wrong. The functional bladder capacity is small. So we need to ask these questions. And this is the person perhaps with whom we will have to work more. Maybe one has to consider a urodynamics in this person.
And Dr. Sanjay Sinha sir, your opinion?
So I agree with Rajesh that there is possibly an element of an overactive bladder kind of a picture. We don't have his daytime frequency given here. So I don't know what's his daytime mean voided volume, but the night voided volume, again, mean voided volume is on the lower side. So the thing that strikes me is, I mean, overall, my impression in this patient is probably an overactive bladder complicated by aggressive by polydipsia. I mean, his 24-hour urine volume is pretty high, 2.3 liters. So somebody who's got a problem of that nighttime frequency and also has a 24-hour urine volume of 2.3 liters, that should be the first thing to address. You can see here, if you can get his 24-hour urine volume down to 1.5 liters, which is the usual for most adults, you'll cut down his overall 24-hour frequency by at least 3 times or 4 times. So that should be the first step here, because his mean voided volume is about 150, 200, and he's passing 2.3 liters over 24 hours. So I would counsel this patient, target urine volume 1 to 1.5 liters in 24 hours, and then come back to me and let's see how much of your trouble remains. And then if you're still bothered, I would see if the daytime voided volumes are on the lower side. I'd add a drug, an OAB drug, and see what happens.
So I think, sir, what my impression is that the history and his uroflowmetry and voiding diary is not matching. So there is a role of detailed bladder diary. Again, there is a role of urodynamic study in such scenario. So the patient needs further evaluation before starting any treatment. And I think the patient was evaluated and other underlying causes were eliminated. As advised, he was initially advised lifestyle modification, cessation of fluid intake 4 hours before bedtime, avoid caffeine and alcohol before bedtime. And then again at 1 month follow-up, he was having nocturia bothersome, which was around 3 to 4 times per day. Dr. Tanuj, sir, any role of alpha blocker at this point of time? He is having no daytime symptoms. He's absolutely normal, only now complaining of nocturia 3 to 4 times.
One thing which you had mentioned during the history but was not written there is that he's sleepy during the day.
He's lethargic.
He's lethargic during the day. So I think that even though he's not obese and all that, but I think that should also be looked into. And also we should look at what time he's consuming how much fluid. Suppose he's having 3-4 glasses only at night and 3-4 glasses only in the day, then he'll have this kind of symptoms. Now, coming back to, sorry, you asked me was role of alpha blockers.
Yeah.
So if I look at his Euroflow, there is some terminal dribbling, but yeah. So I will first of all ask him whether this is representative of how his flow generally is. Although voided volume is 200 ml, it's not a super sort of thing. He's not voided to too much amount so that it does not correlate. But still, I would ask that is this how you usually void? And if he says sometimes he does have obstructive symptoms, then I might think of adding alpha blocker. Per se, otherwise, I don't see any reason for adding alpha blocker.
So I think again a very important message of a good look into his bladder diary, whether he's taking any extra fluids, but that we have taken care with our general lifestyle modification that we have advised him, and probably because of that there is some improvement in nocturia. The main important point of this discussion is at this point of time, should we start desmopressin? Because there is no here is a role of desmopressin or what medical management can we start?
So Hemant, before you start desmopressin, it's crucial to document his 24-hour urine volume has come down to 1.5 liters. Otherwise, you run the risk of aggravating dilutional hyponatremia. So if the patient consumes large amounts of water producing 2.5 liters of urine in a day, and now you give desmopressin, he'll develop hyponatremia, even if he's a young patient. So the first step is you've got to get the urine volume down and check on a bladder diary. So here it's crucial to have another bladder diary to check what's happened. And once the urine volume has come down to under 1.5 liters, I would ordinarily put this patient first on OAB medication. I might even add an alpha blocker just to see what happens, because once in a while we've seen patients with high flow obstruction. So I wouldn't do a urodynamics right now, but I would put the patient just to see what happens. I mean, you could giving a short, brief trial over a week or two, there's really nothing lost to check what happens. But I would do all that before thinking of desmopressin in this patient.
So again, sir, very important comment is that we have to again reevaluate the patient with good bladder diary. We have to rule out any polydipsia because that will add to the side effects of desmopressin. And we can have a trial of alpha blocker plus minus anticholinergic because they are more safer medicines. And we can see if there is any further improvement in symptoms. Suppose there are no improvement in symptoms, and we plan to go ahead with desmopressin. So, Dr. Sanjay Goyal, sir, what is your prerequisites? Like how you start desmopressin with what dose and how you follow up the patient?
Okay. First thing is that desmopressin, if it has to be started, it has to be started in the minimum dose, and you have to follow with the serum sodium measurement regularly after 1 month. And as Dr. Sanjay Sinha said that first we have to bring down the intake of the fluid intake. Otherwise, the patient will be going into the dilutional hyponatremia. And this looks to be the main cause in this case because the overnight excretion of the urine is approximately 1 liter, while the total excretion of the urine, 24-hour urine, is 2.3 liter. So he is passing more than approximately 30% of the urine, and he is a young male. So he goes into that area, he goes into that category. So you have to basically bring down the fluid intake and then start with the minimum dose of the desmopressin, and then follow up with the serum sodium.
So, Dr. Rajesh Teneja, sir, just I would like to know your protocol, how you start, what investigation, when you investigate with serum sodium like hyponatremia is a real problem. So, what are the specific instructions when starting desmopressin? What are the pre-investigation you will do in such case? What dose, what brand you will start?
So See, we have been conventionally using oral, which is Minirin 0.1 milligram, but now the nasal sprays are available, which are 60 microgram dose in one shot. The requirement is that you have to be very strict with intake output. As Sanjay has emphasized, that you have to know that he is not keeping too much water inside his body, because once you start giving desmopressin, the easiest method, if you can't do sodium potassium, is still to ask him to have intake output charting and see how much is he retaining. Because if you give desmopressin for 12 hours, it will act. The rest of the 12 hours, it is likely to reverse and he can have polyuria during the day. That can happen. So if there is a continuous accumulation or cumulative accumulation of your fluid in the body, then one has to really check the sodium and one has to give drug holidays. You have to stop desmopressin. Maybe you have to give him alternate day instead of daily. That you can do, but I'm still worried because I think this person has a small functional capacity and I'm not comfortable because I haven't found a reason why he should have a small functional capacity of the bladder. For example, if somebody has carcinoma in situ of trigon, he will come with a small functional capacity of bladder. Those are my concerns. So I would certainly go ahead and do a urine cytology in such patients, because they will, on ultrasound, they'll miss anything in the trigon. They'll miss small polyps in the trigon. And that can be a cause of, because what he's having is a small functional capacity, which I think I would not be comfortable without treating that, going on to the further things like desmopressin. But yes, if we have excluded everything like that, and this is the protocol for desmopressin, you must do sodium before, you must do it after a week, you must do after 2 weeks after that, and then every 2 weeks at least, and keep a chart of intake output. Try to tell them the requirement is to have intake output. And the first sign is headache. So you tell them that if you have headache, or if you have giddiness, or if you have things like forgetfulness, or the family members see that he has some cognitive behavioral changes, it can be because of low sodium, and he should be immediately brought into the hospital with sodium level checked and skip the dose of desmopressin at the first alert.
Thank you, sir. So, Sanjay Chana, sir, any cutoff levels of sodium where you will not prescribe, or which is your like, how will you go about it? What is, you prefer intranasal, sublingual, oral?
So I think I would risk stratify. So we know that women are much more likely to develop hyponatremia. Elderly are much more likely to develop. So let's look at risk factors, and if they are there, then be extra cautious. So all the things Rajesh said very rightly, I'd look at that. And so I don't have a specific preference for what type of preparation, but there's some limitations in the dosages that we have. So the melt form gives about, I think, 60 micrograms or something you can get through the melt form. The intranasal spray, which delivers 0.12 milligrams, has an effective delivery of, I think, 89 or some micrograms. So these are the lowest dosages that I am aware of. But if you look at some of the literature, it seems to suggest for women and elderly patients, you should actually be starting at even lower dosages. But we don't have those dosages available to the best of my knowledge. I'm not very sure it might be available. So you need to start at low doses, as Rajesh said. And at each step, you need to reassess the sodium and the patient's bother. And if the patient has a starting sodium of less than 130, I wouldn't start at all. And in elderly and patients, especially women, I would, and by elderly, I mean above the age of 75, I would almost not use it at all. So the risk above the age of 75 goes up dramatically, especially for a female patient. And you can end up with a mortality. So you need to be very cautious in those patients. So I would ordinarily do all urological things before I give desmopressin. Let me put it this way. So, and especially because this patient, there's some suggestion of a daytime urgency, because the mean voided, the pre-void volumes on the ultrasound are low. The uroflow volumes are on the lower side. So everything suggests there's possibly a daytime symptom. That's why I spoke about using OAB medication.
Can we quickly wait?
Yes, sir. Yeah, so sir, I think this is the last 2 slides. So very valid inputs that this patient needs further evaluation. But I just wanted to make a point that if we have to start desmopressin, these are the very valid points made by Dr. Sanjay Sinha sir and Dr. Rajesh Taneja sir. I'll just share some points. In 2018, the US FDA approved 2 lower potency desmopressin analog, of which one is still available, sublingual, for the treatment of nocturia due to nocturnal polyuria. Desmopressin, we all know what it is and what the role is. So basically, the formulation which is available is desmopressin. As Dr. Sanjay Sinha sir said, that the recommended dosage of desmopressin acetate is 27.7 and 55.3 microgram tablets. But what we have is melt form 60 microgram and 120 microgram. Now they had to be taken without water 1 hour prior to bedtime. Hyponatremia was more prevalent at higher dosage in older individuals and in women, as Dr. Sinha sir has already pointed. Intranasal Noctivia, again in the form of Minrin, it is available internationally. It is available as Noctiva. It is available as 10 microgram per spray, and a dosage range of 10 to 40 microgram per day. But in India, it is available in 0.1 ml, which is approximately 100 microgram. So in India, both sublingual and nasal, it is available at a higher dose. That is why we see a lot of hyponatremia when prescribed. We don't have an international dosage like in Noctivia, 10 microgram per spray. In India, what is available is Minrin, it is 100 microgram per spray. And again, the melt form, it is 30 and 60 somewhere. Here we have 60 and 120. Oral tablet is used is off-label 0.1, 0.2 absorption, because absorption from GIT can be variable and it is limited about 5%. Therefore, the oral drug has about 1/10 to 1/20th the potency of the nasal form. 0.1, 0.2 dosage are available, should not be taken with meals and started as lowest possible dose. Efficacy, desmopressin tablet studies have shown long-term reduction in nocturnal void compared with baseline in both men and women, while increasing the initial sleep period by 2 hours in both. And this is what matters, because the initial sleep period we want to increase. All formulation are associated with hyponatremia. Gender sensitivity is there, more common in females than male. And the risk of hyponatremia is less than 1% in younger than 65 years of age and 8% in those older than 65 years of age. Contraindication being hyponatremia less than 135 milliculents per liter at baseline, SIADH and history of hyponatremia, history of congestive cardiac failure, use of systemic corticosteroid, polydipsia, as Sir has said, we have to rule out, otherwise it will increase the chances of heart failure, diminished renal function. Desmopressin should not be given to elderly patient, already said, and monitor the serum sodium levels within 7 days and then 28 days. Also, monitor the side effects like headache, dizziness after initial or incremental dose. Then continue to check sodium levels every 6 months. I think this brings, sir, thank you, sir. Thank you to all the panelists. And this brings to the end of our case presentation.
Thank you, Dr. Hemant, for having conducted this so effectively, and all the panelists for taking part in it very energetically. But before we close, I would like to invite comments from Dr. Sanjay Goel and Dr. Sanjay Sinha. Dr. Sanjay Goel from the Uttarakhand Society, he is heading the society as a president, and Dr. Sanjay Sinha as the president of the Female and Functional Urology Society of India. Dr. Sanjay Goel, please.
Yeah, thank you very much, the leadership of North Zone, for giving us the opportunity to present ourselves as a group. When Rishi, when you spoke to me and you told me that we are going to talk about nocturia, you know what was the internal processing going on in my mind? I was just thinking, nocturia, who talks about nocturia? We always talk about the glamorous things, the things which bring us the limelight, like laser. We talk about the robotics. And suddenly I remembered one of the incidents, one of my colleague, orthopedician, he was facing. He was working with me, and he was coming very late in the morning. One day I asked him, what happened? Why you are so groggy? Why you are so lethargic and without any energy? He told me that I am getting up 5 to 6 times at night to pass urine. And I am not able to sleep. as the night nears, I have so much of phobia that I'm scared. Everybody's sleeping, and I'm awake like a night owl. So one day, what he did, he took double the dose of clonazepam that today I want to sleep. He just found himself lying in the pool of urine next morning because he could not stop nocturia. So that was the moment I thought that nocturia is a subject which is hardly being covered, and the limelight is being stolen by the retention urine obstruction. Every company is making drugs for the lower urinary tract symptoms which are obstructive, and there is hardly one company which makes drugs for nocturia. So I discussed with few of my colleagues, and they agreed with this. And I'm so happy that we talked about it. There was too much, and I'm very sure that it's going to be extremely useful for us. And I'll not be surprised that tomorrow maybe more than one company which is making mineral. There might be many companies and many representatives standing outside of our OPD and introducing those drugs to present ourselves as a group.
Thank you so much, sir. Before that, I think we ourselves need to dwell more on the pathophysiology of nocturia as a symptom and treat our patients accordingly. Dr. Sanjay Sinha, please. Sir.
Thank you so much, Uttarakhand Urology Association and North Zone for involving me personally, as well as the functional urology section. We really appreciate it. And it was a wonderful set of discussions that we had. And I really learned from discussions there, all the discussions. Thank you so much.
So thank you, sir. Thank you, Uttarakhand Society and FFUS again for being part with the North Zone Society for this webinar. And we'd like to actually keep the channels open for any subsequent such programs that we may plan in the near future. Thank you so much once again, all the faculty who have participated in it and all the audience as well for having taken part in the discussion. Thank you so much. Good afternoon to everybody. Thank you.
Thank you.
Thank you.